Future Abhishek.
Hello.
Abhishek.
It is coming. Please move this window away from the shared application.
Dear colleagues, medical science is a rapidly advancing field where yesterday's facts may become matter for the archives to store, and today's fact may not find agreement with experts of tomorrow. Continuing medical education is therefore an integral part of medical profession. Today's Global Cardio-Metabolic update is planned by the organizing committee of the Second World Congress on Cardiometabolic Medicine, which is scheduled to be held in 2021. The program will cover diverse aspects of cardiometabolic medicine, like cardio-renal benefits of SGLT2 inhibitors, CV risk reduction with GLP-1 RAs, emerging concepts in hypertension, smoking and cardiovascular disease, advanced echocardiography, applications in clinical practice, and nuances of DAPT, current status of HCQ in COVID-19, metabolic pancreatitis, etc. We have a galaxy of speakers to address to you on these issues, like Dr. Prakash C Deedwania, renowned cardiologist from United States, Dr. Venkata S Ram, hypertension expert from United States, Dr. Navin C, Nanda, echocardiography expert and father of echocardiography, and Sandeep Gupta, very renowned cardiologist from UK, Dr. Anil Pareek from Mumbai. I'm sure the proceedings of the program will immensely contribute towards better patient care. I cordially invite you to actively participate in this CME program on cardiometabolic medicine, and I'm sure the proceedings of the conference will immensely contribute towards better patient care. Thank you very much. I'll request Dr. Abhishek to start the first case. Dr. Abhishek, please.
Welcome all delegates to this scientific feast Global Cardio-Metabolic Update 2020. First of all, I want to congratulate organizer for organizing this web meet with speaker across the globe in such a difficult time. Now I invite Dr. Piyush Manoria, Chief Gastroenterologist and Hepatologist, Manoria Hospital, Bhopal, to deliver his talk on an interesting case of metabolic pancreatitis. Over to Dr. Piyush, please.
Thank you, sir, and chairperson. Today, I will be speaking on interesting case of metabolic pancreatitis. A 28-year-old obese male with no addiction and without any comorbid illness presented to me with chief complaints of severe epigastric pain in abdomen since 2 days, which was continuous and radiating to the back. It was associated with difficulty in passing motion and flatus and was relieved temporarily with injectable analgesics. There was no associated history of vomiting, fever, jaundice, reduced urine output, no history of GI bleed or distension of abdomen. He has similar illness, severe pain in abdomen 2 times in the past, and in that time also all the investigations, including amylase and lipase, were normal. He was non-alcoholic, non-smoker, and there was no history of any IV drug abuse. There was no significant family history. On examination, he was having tachycardia, tachypnea, and his baseline saturation on room air was 94%. He has a high BMI of 33.12 kgs per meter square. On per abdomen examination, the abdomen was slightly distended, tender, while there was no organomegaly and no lump was palpable. Other systems were also unremarkable. So then we proceed to investigation, and his baseline lab value shows increased total WBC count of 18,100. The LFTs and urea creatinine was normal. His sugars were raised. A1C was 7.6, and the amylase lipase that we have done on day 2, they were normal. But as the pain was typical of acute pancreatitis, it was epigastric, radiating to the back, associated with not passing flatus and motion. He has similar severe pain in the past also. So we have a high suspicion, clinical suspicion of acute pancreatitis. And he was an obese male with uncontrolled diabetes. So we just take out his blood and see his serum, and it was milky in color. So, and then we proceed to his lipid profile, and as you can see his lipid profile, his triglyceride was more than 6,000 and total cholesterol was more than 1,000. So then again, the amylase and lipase was normal initially. Then we asked the lab to dilute the sample 10 times, and then the real value of lipase has come, which was more than 7,000. The sonography abdomen was also showing hepatosplenomegaly. So we proceed to CT abdomen, which shows acute pancreatitis, and a final diagnosis of hypertriglyceridemia induced acute pancreatitis was made. We have started on symptomatic and supportive treatment. Lipid lowering drugs, anti-hyperglycemic drugs were started. And with this treatment, after 3 to 4 days only, his triglyceride dropped to less than 500 milligram per deciliter. So it was an interesting case of hypertriglyceridemia induced pancreatitis, which we missed very often nowadays, and the pancreatitis is labeled as idiopathic pancreatitis. So it is a well-established cause of pancreatitis, but it is an underestimated cause. It is the third most common cause of acute pancreatitis after gallstones and alcohol. The triglyceride level should be more than 1,000 milligram per deciliter to cause acute pancreatitis. And in all cases of acute pancreatitis, it has been seen in 1 to 7%. While mild to moderate elevation of triglyceride is seen in all causes of acute pancreatitis, but triglyceride to cause pancreatitis, the level of triglyceride should be more than 1,000 milligram per deciliters. The clinical feature will be like that of any other cause of acute pancreatitis. Really, we can see eruptive xanthomas and lipemia retinalis due to excessive triglycerides in the blood. The most important and most easy clue to diagnose hypertriglyceride-induced pancreatitis is just to look at the serum of the patient, which will be milky or lipemic in color, and you can make the diagnosis of acute pancreatitis bedside. The triglyceride level will fall rapidly after 3 days of fasting, as the patient will be kept fasting as a treatment of acute pancreatitis. So the triglyceride level should be taken at the time of admission of the patient. Otherwise, you can miss the hypertriglyceridemia, as the patient will be kept fasting. And if you do the triglyceride level after 3 to 4 days of admission, the triglyceride level can very well be less than 500 milligram, as was in our case. If we see the lifetime risk of pancreatitis, in general population, the risk is 1%, while if the triglyceride level raised to more than 1,000 milligram per deciliter, the risk is 5%. And if the triglyceride level is more than 2,000 milligram, the risk is 10 to 20%. So there is a linear correlation between the risk of pancreatitis and the value of triglyceride in the serum. Though the pathophysiology is not fully understood, it has been said that the plasma triglyceride level increase beyond the enzymatic capacity of the pancreatic free fatty acid, and the free fatty acid accumulate in the pancreatic duct, which leads to injury to the pancreatic acinar cells. This is a flow chart which explains that whenever the chylomicrons are increased, the pancreatic lipase converted into free fatty acids. The free fatty acids are excessive, and the pancreatic lipase cannot convert the excessive free fatty acids, and it leads to activation of trypsinogen into trypsin, and the cascade of pancreatitis start. The second theory is that as the chylomicrons are the largest largest of the lipoproteins, they occlude the pancreatic capillaries, leading to pancreatic hypertension and acute pancreatitis. Diabetes is the most common secondary factor in patients with hypertriglyceridemia-induced pancreatitis. Mostly the patients in which the pancreatitis is precipitated, diabetes is the most common secondary precipitating factors, and they have familial hypercholesterolemias, and in which the secondary factor like diabetes or alcoholism precipitate these factors, which leads to acute pancreatitis. As we have seen in our case also, the pancreatic enzymes are falsely low. So we have to be highly suspicious. If the clinical suspicion is very high, we have to dilute the serum 10 times to know the exact value of lipase. And at the bedside also, we can take the blood of the patient in the red vial and convert it into serum and can see the color of the serum. If it is milky or lipemic, the diagnosis is made bedside. The initial treatment is like that of any other cause of acute pancreatitis, which includes the pancreatic rest by keeping the patient nil orally and aggressive intravenous hydration and analgesias. The triglycerides should be checked at the time of admission in every cases of acute pancreatitis of unknown etiology. The fibrate should be started during the admission as it lowers the triglyceride by increasing the lipase activity. It is the drug of first choice for lowering the triglyceride and mostly given in the dose of 100 to 300 milligrams per day. The niacin is the second line of the drug, and if the triglyceride is very high, it is combined with fibrates, but its side effects like flushing, hyperuricemias, hepatotoxicity, glucose intolerance, pruritus limits its use sometimes. Omega-3 acids can be used as an adjuvant in adjuvant cases, in refractory cases, and adjuvant therapies, while statins are not preferred for lowering triglycerides. Many newer therapies have come in refractory cases. If the patient is not responding and the pancreatitis is severe, you can do plasma apheresis. It will decrease the triglyceride level to more than 2/3 in 1 or 2 sessions, and it can reduce the severity of pancreatitis. But in studies, it has not conclusively shown that it reduces the mortality or not. The other new drugs which has come is the infusion of insulin and heparin, as it increases the peripheral lipoprotein lipase activity and increases the hydrolysis of triglyceride, so reduces the serum level of triglyceride and reduces the severity of pancreatitis. While at the time of discharge, we have to advise diet and lifestyle modification. Avoid they should use low-fat diet. Alcohol should be stopped. Weight reduction should be done. Strict diabetic control. If any precipitating medication of hypertriglyceridemia is there, they should stop. The fat consumption should be less than 7% of the total calorie intake. So, ladies and gentlemen, to conclude, I will say that hypertriglyceridemia is an important cause of acute pancreatitis. Presentation is similar like that of any other etiologies of acute pancreatitis. To cause pancreatitis, triglyceride level should be more than 1000 milligram per deciliter. Lipemic serum is the classical and distinguishing initial sign. The triglyceride level should be done at the time of presentation of the patient. The secondary factors like alcoholism, diabetes, obesity, and medication is mostly present in patients who present with pancreatitis. Initial treatment is similar like that of any other etiologies. There's no definitive guidelines which exist for this specific entity, so you have to treat case by case. Long-term therapy with fibrates plus minus niacin is needed, and reduction of triglyceride to less than 1 gram per deciliter will prevent the further episode of it. Thank you.
Dr. Piyush Manoria has presented a very unique case of acute pancreatitis. Now this meet is open for discussion.
Chandrasekhar, are there questions from the chat box? You put the questions from the chat box.
Can I ask a question, Piyush?
Yeah.
Rosuvastatin, do you think it has a particular advantage compared to all the other statins with triglycerides? I know that you did mention it's not the first choice in terms of statin therapy for hypertriglyceride, but do you think it does have a bit of an advantage? Rasuva?
The studies have not conclusively found any benefit of one statin over the another. And still there's doubt that statin should be given for hypertriglyceridemia or not. And so between the statins, it is not clear that any statins is beneficial in reducing triglyceride or not. So
okay.
I think the quantum of elevation of triglyceride is so much so that different choice of statins may not be a great issue, because you have to lower triglycerides by enormous amounts.
The drug of first choice will be fibrates only. Fibrates, niacin, and we can add omega-3 fatty acids.
Dr. P, is there any difference in the clinical presentation of pancreatitis due to other causes like gallstones and others, or alcoholic, compared to elevated triglycerides?
The clinical presentation is similar to like that of any other pancreatitis. And we have to be highly suspicious if the patient is non-alcoholic and gallstone is not there in ultrasonography. The patient is obese, diabetic, metabolic syndrome is there, and patient is having recurrent abdominal pain. So we should be highly suspicious of this entity. And it is not so uncommon, and it's mostly missed.
What is the role of seroglitazar, which is available in the Indian context and not available in the other countries? Does it happen?
Yeah, it is an off-label indication in this entity. It has been recommended for diabetes-induced hypertriglyceridemias. But if the patient is non-diabetic also, we can use it, but it will be an off-label indication. It does help in reducing triglyceride, and sometimes it has to be used.
Now, what is the magnitude of reduction in triglyceride with seroglitazar? Any experienced? How much triglycerides are reduced with seroglitazar, and what is the dose?
The dose is 4 milligram per day, and it has to be used lifelong. The drugs to reduce triglyceride has to be given lifelong. The exact value I cannot commit. It is not mentioned. The exact value of triglyceride which is reduced by seroglitazar.
30 to 40% anyway.
Okay.
So what is the take-home message for the physicians and even the cardiologists who may see patients with hypertriglyceridemia?
Yeah, the take-home message is that in any case of suspected acute pancreatitis, where the patient is diabetic, obese, and have some features of metabolic syndrome, you have to be highly suspicious of this entity. And initially, the lipase amylase level can also be normal, because the mechanism by which they are tested, they are hampered because of the lipemia of the serum. So the amylase lipase can also be less than 3 times initially. So you just, any case which you are highly suspicious, you have to check the serum of the patient and ask the lab persons to dilute the serum to more than 10 times. And then the exact value of lipase will be there and the serum will be lipemic. Otherwise, if you miss this case, the patient will have recurrent acute pancreatitis, and for lifelong, he will having episodes of acute pancreatitis. And he will be labeled as idiopathic pancreatitis. So it is very important to be in our mind that this is also one of the entity which is not so uncommon.
Any other questions or comments? Dr. Chandrasekhar, any questions from the chat box? Okay. Dr. Pankaj, please start the next session. Dr. Pankaj, are you able to hear?
Yeah.
Please.
Now, for the next session, I will invite Dr. Sandeep Gupta, a consultant cardiologist, Whips Crossbars Health, NHS Trust Hospital, London, UK. And he has several times visited us in Bhopal also. And he's an excellent orator. And we are all eager to listen to him and what he says about smoking and cardiovascular disease. What particularly is the role of cardiologist in the prevention of smoking? Over to you, Dr. Gupta.
Pankaj, thank you very much, and Professor Manoria as well for organizing this. Can you see my slide and can you hear me?
Yeah, we can hear you and we can see your slides also.
Lovely, thank you very much. And I do give you guys credit for arranging this, but also to bring this topic into a cardiology congress, because I think it's not that commonly done. And one of the problems is that the cardiologists are saving lives in so many different ways. in coronary intervention, in EP intervention, in hypertension, in hyperlipidemia, etc. And now, what is our role in smoking cessation? And I think it's important. So, as you know, we're now in a world of over 7 billion people, and every year about 17 million cardiovascular deaths. And they are not in rich London, Tokyo, and New York. No. 80% of the deaths are in developing or middle income, low income countries. Now, if we forget about the deaths, if we look at survivors, in an average year, maybe 20 million people survive an MI or stroke. Now, the reason I say that is that there is not a single cardiologist on the planet who cures a patient from coronary disease. They all come back. And my day in the cath lab Wednesday, 8 angiograms, 6 of them were previous bypass and stent patients. It's so miserable to do a ward round in coronary care and the emergency department. We see the old faces. Our OPD is full of follow-up. So when you see a patient who's had an MI, stroke, or peripheral vascular disease, do you know their chance of a further MI and stroke is 5 to 10 times greater? So this is the concept of secondary prevention, lifestyle changes, and lower is better. So I've often, when I've come to Bhopal and India, I always give this conclusion of 3 words: lower is better. So if you look at risk factors, LDL, blood pressure, your waist circumference, your proteinuria, your hemoglobin A1C, lower is better. For example, with hypertension, if you look in the yellow here, that we're now realizing that the optimal blood pressure is aiming towards 120/80. So we are all probably pre-hypertensive. And this is a slide of what, how many years ago? About 22 years ago. And even then, in 98, nearly 40 trials summarizing with lipid lowering, lower is better. So if you look at different countries, who tends to live the longest? The Japanese. Yet the Japanese, they smoke a lot, and yet they live long and they have lower coronary rates. And one reason is that their blood cholesterol is so low. So again, just emphasizing how we're going lower and lower for the traditional and established risk factors. This cartoon is about your heart rate, your sinus heart rate. And if you look here, which animals live longer? Those with lower heart rates, humans and camels. So if we go back to the very important study by Salim Yusuf and colleagues into heart, and the question was, in 52 different countries, what are the risk factors for myocardial infarction? Is an MI in Bhopal the same as in London, the same as in Johannesburg, and the same as in Dundee and Sydney? Yes, 80% of the world's MIs are explained by 4 risk factors: diabetes, cholesterol, blood pressure, and smoking. And one thing about the InterHeart study was that smoking accounted for almost 40% of the attributable risk for first MI. So a reminder about the headlines with cardiovascular disease and smoking. If you look at patients who are smokers, they're 5 times more likely to have non-fatal MI. And if you look at smoking in general, it risks the death from CAD by 70%. So one cigarette, the ingredients may be 2,000 chemicals, of which 50, 60 are direct carcinogenics. And how many patients or the public are aware that a cigarette contains vinegar, cadmium, candle wax, barbecue lighter, road tar, all of these horrific chemicals? So in a world of 7 billion, 1.2 billion smokers, 30 million smokers added every year, and majority are in the developing countries. And if you look at the causes of death in the world, 8 common causes, tobacco is responsible for 6 out of 8 of the deaths. And where do the smokers live? Well, 50% of the world's smokers only live in 4 countries: China, Indonesia, India, and Russia. And if you look at India, this is looking at male tobacco, chewing, and smoking. You can see there is regional differences, as in most countries, in terms of smoking rates. So by the end of today, around 3,000 people will die in India from smoking-related disease, huge number. And by the end of today, tragically, around 400 new young smokers will take up the habit. But let's turn this to a little bit of optimism. If we look at cardiology and what we've done in secondary prevention, we should be proud of ourselves with all of these aggressive interventions post-MI. Primary PCI, antiplatelet, beta blocker, ACE, statins, everything reduces by 20 to 30%. And if you look, when you come in with your MI and you get no secondary prevention, your death rate is high, 8 to 10% every 2 years. But if you get that right cocktail of intervention in terms of secondary prevention, things go down. And you know, when you and me have an MI, we want to leave hospital with 2.3% risk, not 8% risk. So we want the cocktail. Now, if you are a smoker and you stop smoking on the day of your MI, you know the benefit? 36% reduction. So basically, stopping smoking after your MI is better than your aspirin and your statin. It's as good as. And the other, this is the actual meta-analysis in 2003 that showed this event reduction with stopping smoking after MI. Now, the other thing we like doing in cardiology is not just webinars and Zoom meetings to our colleagues. We like going on media. And I remember going on the radio earlier this year before COVID, talking about risk factors. And the guy at the other end listening to me said, Dr. Gupta, I'm fed up of listening to you because all you say is eat this, don't eat this, walk more, stop this. He said, when your time is up, your time is up. Leave us alone. And you know what I said to him on the radio? I said, Mr. Khan, in the year 2020, it's very difficult to die, very difficult to die. But if you don't stop smoking, walk more, eat properly, take your blood pressure tablets, you're going to need your leg amputated. You're going to need your third stent. You're going to need your oxygen cylinder for heart failure. So remind our patients that the risk factors and the interventions we're doing is not just to give you more years of life, is to give you healthy years of life. So atherosclerosis, if you carry on smoking, it progresses. But if you stop here in green, you could slow down the coronary atherosclerotic plaque disease progression. If you look at bypass surgery, if you carry on smoking after a new set of arteries, your bypass, there's an over 2-fold risk of coming back for your second bypass. And even after coronary stenting, we know in the cath lab, we see stent occlusion, we see stent restenosis, often in those who are non-compliant with their medications and those who carry on smoking. Now, some of you might say, well, Dr. Gupta, I only have 1 or 2 cigarettes a day. I'm surely fine. But the answer is that even if you smoke 1 a day, it's worse than 0 a day. So we need to be emphasizing that it's total smoking cessation, not just cutting down. This is a complex slide, but one of the main ingredients of cigarettes and other kinds of tobacco is nicotine. And nicotine is very addictive, but also nicotine causes pro-thrombotic processes, pro-inflammatory processes, dyslipidemia, and direct carcinogenic and direct damage to causing vascular injury. When in the cath lab we see ST elevation MI and they're young, 2 things we often see: low HDL, so less cardioprotective, and higher rates of smoking. And why are why do the governments of the world suddenly decide on banning smoking in restaurants, in bars, and hotels, and railway stations? The reason is You know, the non-smokers, you and me, we were fed up of dying related to smoking. So this ban on public smoking is related to secondhand smoke reduction. So this is a picture autopsy of nice clean lungs and heart of a non-smoker who died in a road traffic accident. Non-smoker. This is a smoker. And you can see the big difference in terms of damage to the heart and the lungs. There are different kinds of tobacco. We know that. In India, there's a lot of people are chewing tobacco. In Sweden, they inhale it through their nose, snus. In Middle East, they have shisha pipes. But all of these things have the same endpoint damage. This slide, you will always remember. You will never forget this slide. For every one cigarette you smoke, you will lose 11 minutes of your life. And every time I show this slide, I see people adding up. How long have I got left to live? Question, how many cigarettes are needed to cause an MI? Maybe just one is enough if you are vulnerable, if you have genetic predisposition. And it's a bit like liver cirrhosis and alcohol. Look at your road. Let's say every male drinks a bottle of whiskey a day. But out of the 100 males, maybe only 10 will get cirrhosis. So I think there is possibly a genetic predisposition on who will have the endpoint. How quickly does a cigarette cause harm? Well, if you look at the laboratory data, within minutes, there is evidence of free radical damage just by inhaling a single cigarette. It's a bit like a glass of champagne. As soon as you have a glass of champagne, it goes straight to the head. You feel a little bit woozy because of dispersal of the alcohol into the bloodstream. How does a cigarette cause harm? Patients may ask, and you show them this slide, and you say, Mr. Patel, the harm of cigarettes is multifold. It's not just the addiction and nicotine, which is a stimulant, sympathetic stimulant. It's all the other processes that are included in tobacco, causing carbon monoxide, oxidation, free radical damage, endothelial dysfunction, etc. This is an interesting statistic. If you have 1,000 20-year-old smokers, how many are estimated to be murdered? Now you will say it depends where you live, but maybe one. So of 1,000 20-year-old smokers, one may be murdered. And you're usually murdered by someone you know, like your next door neighbor. Next question, if you have 1,000 20-year-old smokers, how many will die in a road traffic accident? And similarly, you'll say depends where you live, but maybe 6 in 1,000. And finally, you have 1,000 20-year-old smokers. How many will die in middle age? Not old age, in middle age from smoking? 250. This is just to emphasize the scale of the harm. Now, let's turn this around, because maybe as doctors, clinicians, and cardiologists, we have a bad habit of scolding our patients. Why are you drinking? Why are you overweight? Why are you not having carrot sticks? Why are you not walking more? But if you turn it around and say, do you know the benefit of stopping, cutting back on alcohol, or walking more, or eating less? Show them the benefit. And it's the same with smoking, because once people stop, you will see improvements in their platelet function, their lipid dysfunction, their heart rate comes down. People say after days they can smell better, they can taste food better, and longer term we will reduce events. So this is the emphasis for cigarette smoking. And then you also tell them, if you've been an ex-smoker for 1 year, just quit for 12 months, you will reduce your cardiovascular, your MI rate by 50%. And if you stop for 15 years, you're like a non-smoker for cardiovascular risk. Every day of not smoking is worth it. Now, we like prescribing blood pressure tablets, but if you have a smoker taking blood pressure tablets, there is some evidence that the medication may not be as effective. We like prescribing statins, but if you have a smoker taking statins, there is some evidence that they may not be as effective. And in a crude sense, aspirin a day to thin your blood, cigarette a day to thicken your blood, that aspirin's not working. Now, taking the step forward for what practical things cardiologists need to be aware of. We need to be aware that it can take a few goes before patients end up long-term quit, because life events come through and they relapse. And it may take 5 or 6 goes. And each time we need to be supporting our patients, not necessarily us as cardiologists, but our team of smoking cessation health professionals. And remember what Mark Twain said, stopping smoking is the easiest thing to do. I know because I've done it thousands of times. So patients do want to quit. If you were to probe your patients and ask them, do you want to stop smoking? Most of them say yes. But how many manage to do it without help? Very few, under 5%. And this is again why health professionals, including cardiologists, need to be involved in helping them quit. This is the brain of a non-smoker. This is the brain of a smoker. I have no idea what this slide means. All I know is that their brains are different. I do know. This just tells you the problem of nicotine addiction and how the receptors in the brain are upregulated. And the smokers need to keep that dopamine kick because it becomes a vicious cycle. And once that dopamine kick goes down, they have craving, they have another cigarette, and the cycle continues. And this is why this important drug, varenicline or Champix, has been effective in reducing or in helping smoking cessation long term, because this drug has 2 properties. One is it reduces the craving and the withdrawal symptoms, but also it combines with the nicotine receptors with nicotine and gives a partial dopamine release. And by this dual effect, after 12 weeks of a course of varenicline, many smokers will say, I don't feel like smoking anymore. So behavioral support and a course of varenicline has been shown way above e-cigarettes, patches, bupropion. This is the best data for long-term smoking cessation. And the other question you may say, well, what about cardiac patients? Is it safe to use? And this study published in Circulation 10 years ago looked at stable cardiac patients. And this is the quit rate with placebo. This is the quit rate with varenicline, very effective. And in terms of safety, no different to placebo. This is in acute coronary syndrome patients, the EVITA study. If you look at quit rate in terms of ACS patients, you can see in gray here, much more effective if you got your varenicline, ACS, and it was safe. And this huge study, EAGLE study, looked at neuropsychiatric and non-neuropsychiatric patients, looking at different smoking cessation interventions. And the bottom line was, huge study published in the Lancet, over 8,000 patients. And if you got varenicline, you were better off than bupropion, NRT, and placebo in quit rates. And this is a study even in India, looking at chewing smokeless tobacco and showing the efficacy of varenicline in patients. So, last few slides. In the UK, we are very pleased. We are now down to only 15% smokers. And I think during the coronavirus and the COVID-19 pandemic, which we're currently tragically in, smoking rates have come down globally as well. I think the biggest benefit a nation can do, a government can do, is ban tobacco in public places. And even when they banned tobacco in public places about a decade ago in the UK, you can see here how death rate from MI just drastically came down, even within the first year. The other thing governments need to think about is taxation. So there's always this carrot and stick effect. Do you give people vouchers and give them advantages to stop smoking, or do you punish them and increase taxation? There is this balance. Cost effectiveness, these courses of varenicline, they may be expensive, But if you look at the end point of reducing events, keeping away from hospital, having more productivity working, smoking cessation is one of the cheapest things we can do. And these are just figures in the UK just showing the expense of cigarette smoking in terms of hospitalization, loss of working days. And this is interesting. You know, we're interested in saving money in a healthcare. For every £1, what's that, 100 rupees invested in smoking cessation, you know what you get back? You get back 250 rupees longer term, because people stop smoking, they have less events, less hospitalization, more working days. So remember that old adage, short-term pain for long-term gain. Am I okay for time, Pankaj? A few more minutes? Yes?
Sure, you can take.
Yeah. Okay. So in terms of summarizing the next stages, cardiologists, we are busy. We don't have enough time necessarily. But what we have to do in our clinics, in our hospitals, in our intervention areas, is to create a team, nurse specialists, pharmacists, people who are trained in smoking cessation. You've got to ask, advise, assess, assist, arrange, and based on the Canadian model, follow up, the Ottawa model. And if you follow up patients, are you taking your secondary prevention? Have you checked your blood pressure? Have you stopped smoking? It is also as effective. A few words about e-cigarettes and vaping. The world is divided into two. One group say vaping and e-cigarettes is better than smoking, but it is a stepping stone to quit. Fine. But the other group, and this includes me, say, where's the long-term data for the e-cigarettes and vaping? There's increasing evidence that it damages parts of the lung and it may have cardiovascular harm. And the third reason I have nervousness with e-cigarettes is that they're flavored, mango, peppermint, green tea flavor. So the youngsters are taking up a new habit and they've never smoked before, but it does contain nicotine. So we've got to be wary about these e-cigarettes. Remember, the world is divided into two. One half, we are focused on doing a measurement and writing a prescription, but we have to keep balance with education. Remember, in a world of 7 billion, 3.5 billion are obese and overweight, 3.5 billion are hungry and starving, and they are often neighbors. The world is divided into two. Today, maybe 10,000 people will die from diabetes and obesity, but 20,000 will die of hunger. So we've got to try and break down this dichotomy. The good physician treats the disease, the great physician treats the patient. And remember this old Chinese adage, superior doctors prevent disease, mediocre doctors treat disease before it's evident, and inferior doctors, cardiologists, we treat the full-blown disease. This is not my mobile, but you know your State Bank of India number, you know your passport number. All of us need a risk factor number. 130 systolic, 75 diastolic, 4 cholesterol, 6 sugar, 60 heart rate. And if you want to be international, no sugar, no salt, 0 smoking, and 100% exercise. Everyone needs their own personal risk factor number. I think I should patent this concept. What's the biggest room in the world? The room for improvement. Thank you, Pankaj.
Thank you. Thank you, Dr. Gupta, for a wonderful illustration. And there's a lot of message in the chat box, and everybody is congratulating you for a wonderful lecture.
Thank you.
There are a few questions.
Dr. Gupta, one question is second-hand smoking as dangerous as smoking? Second-hand smoke as dangerous as smoke?
Yeah, it's a good question. I don't know the absolute figures, but there is a clear link with second and third-hand smoke. You know what third-hand smoke is? Let's say you've been smoking in a car and you've left the car. There is still tobacco and chemicals lingering, and that can cause harm. So I suspect it's not as potent as first-hand smoking, but there are enough deaths every year globally in non-smokers who live in an environment of family and in the work environment of smokers, and they develop lung cancer or cardiovascular disease.
The second question is, what are your recommendations for avoiding passive smoking in terms of distance and other recommendations? So those who want to avoid passive smoking or second-hand smoke, what they should do?
I think you've got to look at the people who are smoking around you and work with them, because I think this idea of distancing and wearing a mask in terms of smoking is just not practical. I think the emphasis has to be to support the smokers around you, whether it's work colleagues, whether it's friends, or whether it's relatives, or whether it's your family household. They've got to be encouraged to quit it.
There is one question in the chat box. What are the hemodynamics effects of smoking? Dr. Radhika is asking.
So I showed that complex slide where if you look at the harm of tobacco, it's linked with the ingredients. So the ingredients of tobacco include nicotine, and nicotine is a sympathomimetic. It's a stimulant, increased heart rate, blood pressure changes. But the other ingredients of smoking, the harmful 2000 chemicals, are pro-inflammatory. They damage endothelium. They trigger prothrombotic processes, free oxygen radicalized. And for some group of patients, they are pre-cancerous. So I think it's a number of processes that occur. It's a bit like diabetes. You know, when people say, how does diabetes cause atherosclerosis? It's through multiple processes.
The other question
Dr. Satish is asking, patients do quit smoking after the MI, but they again start smoking after a few years or few months. As you said, it is very easy to quit smoking. People have done several times.
Yes.
So how to?
What's the question, Pankaj?
He's saying people do quit smoking, but they again restart.
Okay, yeah. Because
after 3 to 4 months.
And you know, all of us who work in a cath lab and in a coronary care, you know, the patients come in acutely unwell. They listen to everything, don't they? They will take their medicines, they will learn about rehabilitation, and they will quit. But you're right. As things progress, because they lose their symptoms, they're fine, they think they're fixed, they go back to old habits. There is no magic. It's really making sure there's follow-up. And this is what we're bad because we're so busy. So if you follow up patients 6 months, a year,
I will start the session, you play the video of Dr. Nanda.
It doesn't have to be the cardiologist. It's like in California, you know, the health insurance Kaiser Permanente, they get the nurses to knock on the door 1 year, 2 year, 5 year later. Are you taking your medicines? If not, we will cancel your health insurance. So it's almost like carrot and stick.
I'll share you a funny story about smoking cessation.
Yeah.
There was one patient of mine who used to smoke about 20-25 cigarettes a day. One day I called him in my chamber and I counseled him regarding the bad effects of smoking. I told him that if you can die, you can have a lung cancer or a mouth cancer, and you can develop hypertension, everything. So he got scared so much that he immediately went out and smoked 2 cigarettes to relieve his stress.
Dr. Gupta, other question is, after how much time of cessation of smoking the risk of a smoker becomes equivalent to a non-smoker?
Yeah, good question.
Is there any time?
Yeah, I'll give you a time. What the evidence shows, if you've stopped for 12 months, just 1 year, and we know a year goes quickly, because it just seems like we were there last year, a year of stopping smoking, you've already reduced your cardiovascular risk by half. But it takes a total of 15 years to become like a non-smoker risk for cardiovascular. If you stop for 8 to 10 years of smoking, you become like a lung cancer risk of non-smoker and stroke. So cardiac disease, longer period of stopping, 15. For cancer and stroke, they say 8 to 10 years. But those years will go quickly. And so it's worth every day of not smoking.
Dr. Gupta, a few words about e-cigarettes. You know, Indian government have banned e-cigarettes. So what are you?
They?
Yeah, they have. Last year only they have banned e-cigarettes. They have banned e-cigarettes, but they have permitted cigarette smoking. What are you on this? I don't find the logic in this.
It's illogical, isn't it? And you know, and people, I think one of the problems with different governments, not to blame any government, is that the smoking industry does give them a lot of taxation.
Revenue.
Yeah, you know, they say if you ban cigarettes in Indonesia today, tomorrow 6 million people will be unemployed. Does that make sense? It's all linked in, and this is the big problem.
No, but my logic is why they are banning e-cigarettes then. What is the logic in banning e-cigarettes? Does it ban anything?
Dr. Gupta, what drugs in your experience is most useful for cessation of smoking?
So in our practice, and this is not just in the UK practice, but if you look at the evidence, the randomized trials, looking at nicotine replacement, looking at the gum, looking at bupropion, looking at hypnosis, the best evidence for long-term smoking cessation stopping is Champix, the drug made by Pfizer, a 12-week course. And many people are unaware of this, that you can take a course of tablets for 3 months and wow, the greatest chance of stopping. Because what happens, it realigns the nicotine receptors. It makes people feel uncomfortable smoking, and they just don't want to smoke anymore. So varenicline is the answer.
And any data available on COVID-19 on smokers in your country compared to non-smokers?
Yeah, that's a good question, Prakash. I mean, I think, you know, earlier on in the COVID, April, May, there was data, ridiculous data, saying that the smokers were protected.
Non-smokers, you and me. COVID-19 on smokers in your...
Yeah, so basically there was early data suggesting that the smokers seem to be protected from coronavirus. But I think as the months have progressed and more global data has come back, it showed that smoking is a risk factor for being hospitalized or needing more respiratory support. But I don't know the actual figures. I think this is all emerging.
I think time is up. Dr. Pankaj, you can finish the session.
Yeah, thank you, Dr. Gupta, for a wonderful presentation and a very good discussion about smoking cessation. I hope everybody must have enjoyed and learned a lot for this. And I hope that all the doctors will re-emphasize the importance of cessation of smoking, which has found to be more beneficial than not just aspirin and statin for secondary prevention. It is equally beneficial and should be a part of treatment armamentarium, the cessation of smoking. So with this, I conclude this session and hand over the dice to the presenter. Thank you, Dr. Gupta.
Can I just make one request to Professor Manoria?
Yeah.
Yes.
When we meet again in Mumbai or Bhopal next year or year after, will you put me on the stage for the same discussion? Yeah.
Okay. Sure. The next session is on a very interesting topic on echocardiography, that is ejection fraction or global longitudinal strain, currently, which is more appropriate for assessing ventricular systolic function. All of us know we have been using ejection fraction for several decades, but now this global longitudinal strain has appeared. And the advantage of this is that it can detect subclinical left ventricular systolic dysfunction. So to speak on this session, we have no other but Dr. Navin C. Nanda, who is father of echocardiography, and he will be talking on this topic. Dr. Nanda, please.
I'm Navin Nanda from Birmingham, Alabama. And it's a really great pleasure and honor for me to give this talk here at the Global Cardio-Metabolic Congress here, kind of, and which is being arranged by Drs. Prakash Manoria and Pankaj Manoria. It's a great pleasure for me to be here, and I know both of them very well, and it's a real pleasure. So my topic is going to be left ventricular ejection fraction versus global longitudinal strain by speckle tracking echocardiography, which is the more appropriate to use in the day-to-day clinical practice. So let us start off with the left ventricular ejection fraction. Left ventricular ejection fraction by echocardiography has been the cornerstone for evaluating left ventricular systolic function for several decades, despite problems related to image quality, assumptions regarding left ventricular shape, and also regarding echocardiographer expertise. So actually, if you look at it, ejection fraction is really the percentage of blood ejected from the left ventricle during contraction. So one of the formulas for ejection fraction, which no one really talks about, is important to know, is really stroke volume, left ventricular stroke volume, divided by the left ventricular end diastolic volume, and of course expressing that as a percentage, that is what ejection fraction is. When the ejection fraction is less than 50%, it confers 10 to 12 times risk of developing heart failure and 3.5-fold risk of all-cause mortality. Even actually left ventricular ejection fraction in the 50 to 55% range, which is borderline, has intermediate risk for both heart failure as well as for mortality. Left ventricular ejection fraction is inversely related to the risk of developing heart failure, and knowledge of left ventricular ejection fraction is very critical because 50% of patients with heart failure will die within 5 years. So that's LV ejection fraction is really very important. Also, it is useful when we are looking at the efficacy of different medications that we use for heart failure treatment, for example, beta blockers, ACE inhibitors, ARBs, etc. And also, if you think in terms of when you want to put in a defibrillator, intracardiac defibrillator, or you want to have this patient go for CRT, cardiac resynchronization therapy, ejection fraction becomes very critical. It has to be 35% or less, 30 or 35% less before you consider these procedures. Also, when we consider patients for cardiac transplantation, obviously the ejection fraction has to be less than 25%. We also know that when the ejection fraction is low, it also means the patient has chances for sudden cardiac death. And also we know that in the ICU, the ejection fraction is really very high. That again is a poor prognostic sign. So I think ejection fraction is something that we use clinically all the time to make some very important decisions. If you look at the ejection fraction, again, if you there is a study done using more than 2,000 patients. And again, baseline ejection fraction was the single most important predictor for survival in these patients. If you look at the recent European guidelines, ejection fraction is class 1 indication for classifying heart failure phenotypes. As we know now, we have 3 phenotypes for heart failure. One is the heart failure with preserved ejection fraction, which is more than 50%. And then there's a heart failure with reduced ejection fraction, where the ejection fraction is less than 40%. And there's a mid-range left ventricular failure, left ventricular heart failure with ejection fraction, the mid-range ranging from 40 to 49%. There is no question that ejection fraction is a reliable predictor for survival. Lower the left ventricular ejection fraction, the higher cardiovascular mortality, no question about that. And it is an accepted risk predictor worldwide, not only in the Western countries, but everywhere in the world. It's very important. So this is a quote from Dr. Burkett Piskey very recently. And he mentions that we all know how to use ejection fraction, how to apply it, and how to interpret it. It is part of our daily life. That's actually the conclusion regarding ejection fraction. But remember, ejection fraction is also imprecise, and it's an arbitrary method for measuring heart disease. So it's not everything is not rosy regarding ejection fraction, we do have some problems, which I mentioned also in the beginning. When we go for measurements, we have the visual measurements, which is actually very accurate. If you think in terms of in an expert hand, it's very accurate to measure the ejection fraction by just eyeballing or looking visually at the echocardiographic images. On the other hand, if the person is not really an expert and is just a beginner, then there is quite a bit of inter and intra-observer variability, which can range from 8 to 17%, and intra-observer would be about something like 11 to 13%. We use Simpson's method many times, but this is actually, you make assumptions, geometric assumptions regarding the shape of the ventricle. You think in terms of the left ventricle being an ellipsoid model. And so that is obviously a problem when you have patients with wall motion abnormalities or aneurysm. So it is not very perfect. One of the things which has helped a lot now is to use contrast echocardiography, which is used quite commonly now. Once you use the contrast echocardiography, then the LV endocardial body is seen very well, and that actually helps even a less experienced observer to actually decide what the ejection fraction would be. 3D echo, of course, is very, very important because you don't make much of assumptions when you go for 3D echo, and it correlates very well with magnetic resonance imaging, and there is low inter and intra-observer variability also with 3D echocardiography. However, it's not available everywhere. Everyone doesn't have it. And now, actually, artificial intelligence has been added to 3D echocardiography, which further makes it easier to use and more accurate. One has to remember, though, that once the image quality is poor, none of these techniques work, and we really have to use our visual assumptions. So a poor technical window or poor technical examination is always a problem when we try to measure accurately LV ejection fraction. So now let us go on to the other actually modality, which is gaining a lot of prominence recently, and many people think it competes very well with ejection fraction. That is looking at the strain. Strain simply means deformation. For example, if the myocardium is reducing in size from systole to, from diastole to systole, that's also a deformation. If it's thickening, like myocardial thickening, for radial strain, for example, that again is a deformation. So deformation, any deformation in the heart, we can call it a strain. So strain is simply, you need to think of it as deformation. Now here are the various types of strain. You can get various types of deformation. Let me just play it. So here you can see the very first one where my hand is. There's radial strain, and that's something what we maybe use for actually calculate ejection fraction. We remember that the heart has many other functions. It not only actually, you don't have an inward motion of the ventricular walls, but you also have the base of the heart, like you can see here, moving toward the apex. The apex doesn't move much, but the base moves toward the heart here. Base moves toward the apex. So that is another important thing to remember. This is actually what we call strain, and this will be global longitudinal strain. Global longitudinal strain, that means the base is moving towards the apex. So that's what is, when we think of strain, that's what we are thinking. There are other types of strain, circumferential strain, which looks at the left ventricle in short axis. I think I can try to play it again, which will actually look at the left ventricle in short axis. And there we look at the decrease in the circumference of the left ventricle. So that is a circumferential strain. And if you do a 3D echocardiography for strain imaging, which I'll be talking about a little bit later, you can also look at you can actually get a combination of longitudinal and circumferential strain, which is called the area strain. And that again is something which has been found clinically very important. So right now, actually, when it comes to really only the circumferential strain or the radial strain, we don't have that much standardization on these, but we have a lot of standardization. We have good standardization when it comes to longitudinal strain, where we are talking about the base moving towards the apex. Now, one other thing, the heart does three things. One is, of course, all these strain that I showed you. Then there's inward motion that we are calling as the, from where we calculate ejection fraction. But more importantly, the heart also actually twists on itself. twist, where the heart twists on itself, and that is another important aspect of heart function. Now, that is more difficult to do, can be done also, but hasn't been very well standardized. So right now, when it comes to looking at the systolic function of the heart, we base it on ejection fraction and the global longitudinal strain, looking at the base of the heart moving towards the apex, and that's what we look at. Now, when the base moves towards the apex in systole, obviously compared to baseline, it becomes shorter. So therefore, it is plotted below the baseline, and we have a minus sign. So minus sign simply means that the heart is getting, so it is really not an algebraic minus sign. For example, global longitudinal strain of 20% is better than global longitudinal strain of minus 10%. So it's just plotted below the baseline because the heart becomes shorter. The length of the base to apex becomes shorter in systole. So speckle tracking, what is speckle tracking? We need to understand that because they are really small dots due to the interaction of ultrasound and myocardium. They have a very specific signature. Hence, 2D echo can potentially trace them throughout the cardiac cycle. So that is the important thing. So they have a specific signature. So the machine can follow each speckle as it moves during the cardiac cycle. So that's important. So these are small dots, and of course, some of the speckles are clumped together. We call them kernels, but that's not very important. The main thing is to think of them as small dots produced by the interaction of ultrasound with the myocardium. So here is to show you how actually you can take one speckle here on the left side here on the illustration here below, and then you actually look at how that speckle, trace that speckle throughout the cardiac cycle. So that's what speckle tracking echocardiography really means. Now, there is a problem there because when we do a 2D echo, remember, when you do a two-dimensional echo, it's always a thin slice to the ventricle. It's a very thin slice to the ventricle. So if the machine is going to look at a small speckle throughout the cardiac cycle, the chances are you're not going to look at the same speckle because this speckle is going to go outside that plane very, very easily because we are looking at a very thin slice of the ventricle. On the other hand, if you do actually a three-dimensional echocardiography, if you do a three-dimensional echo, then the chances of the speckle moving outside that pyramidal volume, which we get by three-dimensional echocardiography, is much less than what we get from two-dimensional echocardiography. So theoretically, and to some extent practically also, 3D speckle tracking echocardiography may be more accurate than 2D speckle tracking echocardiography because we don't believe in 2D speckle tracking echocardiography. The machine can follow the same speckle throughout the cardiac cycle because it will go outside the thin slice that we take of the ventricle when we look at this speckle tracking echocardiography. So when it comes to this disadvantage of 2D speckle tracking echocardiography, the reproducibility may not be ideal. And of course, we know in the beginning there was significant inter-vendor variability, which is now much less because all the vendors got together, decided how exactly to do speckle tracking echocardiography. So the inter-vendor variability is much less now. And of course, like anything in echocardiography, you have to have good resolution, high resolution images. Otherwise, your speckle tracking values will not be very accurate. I also mentioned here difficulty in following the same speckle from frame to frame. On the other hand, so here is just to show you the speckle tracking. If you're looking at the global longitudinal strain, they are all going to be plotted below the baseline. So this is looking at different segments here. One of the very first studies that we used, 3D speckle tracking echocardiography in Birmingham, Alabama, quite a while ago. And you can plot these various curves here. So here, for example, one segment has strain around 20-25%, another segment is 15%. So the 20%, minus 20% is better than minus 15%, just to make sure you understand this also. The advantages are, of course, 3D speckle, probably more accurate, and also it provides calculation of area strain, which is a combination of longitudinal and circumferential strain, which has also been found to be quite useful. But of course, it's not available on many systems, and maybe with more research going on, may need further validation. So what is normal global longitudinal strain? So if you look at single center studies, the normal global longitudinal strain in males is from minus 17 to 24%. So minus 17 to 24. So if it's less than minus 17, that's not good. That's actually shows reduced strain. And for females, it's a little higher. That's interesting. The females have a little higher strain, from -18 to -26. So something like -17 for male would be the lower limit, and -18% for females would be the lower limit. If you go into the core laboratories, not just single center studies, then the results are a little bit different. Then actually it is actually should be minus here. Then the GLS is -15.9%, -22.1%. But in any case, if you think in terms of 17, 18, that's a good way to think about normal, lower limit of normal values, or I should say, the anything lower than that would be abnormal. So where is strain used? Strain is very important because it can there may be a decrease in the strain, that is the apex to base movement of the heart, length of the heart, before the changes may occur in ejection fraction, and this can occur in hypertensive heart disease. Diabetes is very important, as you know, very important conditions when we look at cardiovascular disease, systemic sclerosis, as well as amyloidosis, and other types of Duchenne's muscular dystrophy, as well as Kawasaki syndrome here. So that is the thing to do. We can pick up a subclinical dysfunction of the myocardium before there's a change in ejection fraction. So that's where the value of the global longitudinal strain lies. Also, when it comes to differentiating the athlete's heart from hypertrophic cardiomyopathy, is very easy. In athlete's heart, you'll get normal longitudinal and other types of strain, while if there's hypertrophic cardiomyopathy, there'll be decreased longitudinal strain. So you can use strain to try to differentiate athlete's heart from hypertrophic cardiomyopathy. Of course, use other values also, like the athlete's heart may have increased LV and diastolic volume. On the other hand, hypertrophic cardiomyopathy will have decreased and diastolic volume. And then you can look at the LA strain, which will be increased early LA strain rate, while in hypertrophic cardiomyopathy, the reduction in LA strain. And also, of course, deconditioning, if you tell the athlete not to work out anymore, then you'll see normalization of some of the increase in LV and diastolic volume, while there is no effect of deconditioning in hypertrophic cardiomyopathy. And another interesting thing that has come of strain is that you can diagnose amyloidosis. Here is the strain here. For example, the red, the bright red means there's increased strain, and the less bright and the almost white here would be decreased strain. So amyloidosis is very characteristic, because there the amyloidosis is shown to not spare the apex of the heart here. So apex of the heart has high strain, while other mid segments as well as the basal segments have lower strain. Something like a cherry on top is how you think of it. You have a cake, white cake, on that there's a cherry. So the red thing is like a cherry. So that's very typical of amyloidosis. So that's where strain has also become very useful. Myocardial ischemia, of course, the decrease in strain is more objective and accurate because you got a real number than just a visual estimation of wall motion abnormalities. Cancer patient, that's very important, because we know that chemotherapy in cancer patients causes cardiotoxicity. And sometimes, and then when there's cardiotoxicity, you have decreased ejection fraction. But by the time the decrease in ejection fraction occurs, the patient's left ventricle may not actually recover, even with very appropriate management. So that LV dysfunction may not recover. So one is trying to find something where you can actually get an idea of toxicity on the heart, detect cardiac toxicity before there's a drop in ejection fraction. And of course, if you think in terms of mortality from cardiac toxicity-induced heart failure is very high. Actually, it's 60% within 2 years. And as I mentioned earlier, almost half of patients LV dysfunction may not recover even with optimal management once they have this cardiotoxicity. So here the strain becomes very important. For example, if you look at the global longitudinal strain, if it's less than 0.17, 0.5%, it is associated with 6 times higher number of cardiovascular events here. And of course, if any strain approximately from 10 to 20% decrease in peak global strain prior to reduction in LVF is a useful prognosticator for cardiotoxicity. So strain has become very important, more useful than ejection fraction in detecting cardiotoxicity in patients in cardiac cancer patients on therapy. So in this case, global longitudinal strain is superior to LVF in cancer patients on chemotherapy. So that's a very important point here. How about valvular heart disease? Of course, we know that when you have symptomatic severe aortic stenosis patients, guidelines are very clear when to intervene. But when you have asymptomatic severe aortic stenosis patients, preserved ejection fraction, timing of aortic valve replacement requires careful monitoring. And here, several studies have shown the LV global longitudinal strain can detect subclinical LV dysfunction and therefore may identify asymptomatic patients who could benefit from aortic valve replacement. Here, for example, is a meta-analysis of different studies and showing the same thing, that there is higher risk of death when with the sensitivity of 60%, specificity of 70% in asymptomatic severe aortic stenosis patients. Even in symptomatic severe aortic stenosis patients with preserved LVF, the baseline who have been treated with surgical aortic valve replacement, the baseline strain of less than minus 14.5% correlated with more long-term deaths than if the baseline GLS was greater than 14.5%. So in valvular heart disease also is useful. Same thing happens with asymptomatic severe chronic aortic regurgitation. When symptoms appear or LVF decreases, that's when we send the patient for surgery. But then the prognosis becomes poor, with an annual mortality rate of 25% without intervention. Here again, global longitudinal strain may be very useful in detecting early LV dysfunction. So this is just to emphasize the aortic regurgitation value of using speckle tracking echocardiography and calculating global longitudinal strain. Mild regurgitation patients also, same thing. Actually, preliminary studies have shown that in patients with functional mitral regurgitation undergoing mitral clip procedure, 3D ST, now here 3D ST has become useful, could predict an unfavorable outcome and persistence of symptoms after the procedure. Of course, all these strain studies are more recent and obviously have to be validated in future. Mitral stenosis also, they found that there may be, investigators have found that the GLS can be reduced, and therefore GLS may be useful in identifying subclinical left ventricular dysfunction in mitral stenosis patients. So actually a consensus on timing of valve intervention in asymptomatic patient preserved LV ejection fraction is lacking though. So in addition to detection of subclinical LV dysfunction, global longitudinal strain is useful for prediction of post-surgical LV dysfunction and may identify high-risk patients who could benefit from early intervention before there's a decrease in LV ejection fraction. That's true for all types of stenosis, aortic stenosis as well as mitral stenosis, aortic regurgitation, and mitral regurgitation. So let us see, in conclusion, what do you want to say? Now, we've got one or two videos. If they play, they'll look very good after this. Both have their own advantages and disadvantages. Strain is new and may have some reproducibility problems. Ejection fraction has got its own problems, as I mentioned earlier. But I think in this way, there is no question of should you use, which is more appropriate, LV ejection fraction or global longitudinal strain. I think to an extent, they are complementary to each other. So it makes sense, the best that we should use both in clinical practice. So the conclusion here is that we don't want to say which is better, LVF or GLS. We use both because some have advantage. For example, in cancer patients, GLS has advantages. And when it comes to heart failure, the LV ejection fraction has a lot of advantages. So both are complementary to each other and both should be used. This is to show you the difference between 2D and 3D echocardiography. As you know, each person is something like a slice through the heart, through the ventricle. And then when they all go into the train, they all get compressed together, so that the 3D images, then of course you can study them again. And these policemen are not looking for pickpockets. They have this special function. They convert all these 2D echoes, 2D slices, 2D individuals into a compact 3D mass. So many times when I see what is the difference between 2D and 3D echo, people say that they may not have understood thoroughly unless they look at this particular video. So, and then of course, when you have a 3D echo, you can still slice it, look at individual segments. So this is the one thing that I wanted to show you about the difference between 2D and 3D echo. Now, of course, the train is ready to leave the station here. Those who came on time are all in the train. I don't know how many of them get suffocated inside, but all of them are inside the train, and those who are late, of course, will not be able to get in. So this is the difference between 2D and 3D echo. You have individual slices, and you put them all together, align them together, and that becomes a 3D echocardiogram here. And this is just to show you, if it'll play, that the heart, the surgeons always shows this heart. This is Dr. Buckberg, very famous surgeon from California, who showed me this and said, look, what the heart does. There is some inward contraction where we calculate ejection fraction. There is some base to apex motion, what we call the global longitudinal strain. But the main thing is the heart is actually twisting on itself. So the twist function is more important. So maybe we still haven't found everything what is best for cardiac function. Maybe in the future we should be relying more and more on this twist function. And it makes sense because if you have a wet towel, like I have got one, it's not really that wet, but just to show you, how do you get the best out of that towel? You don't go by inward motion of the towel. You don't go by actually the up and down motion of the towel, like global longitudinal strain. You twist the towel. You twist the towel, all the housewives know, the dhobies know how you get water from a towel. You twist the heart. So that's what God has done. God has made the heart in such a way that it can twist. And there's another here to show you. And this again was shown many years ago, but we all ignored this. Here is the specimen of the heart and what it is. It's really a linear piece of muscle, as you can see here. And what God has done is to twist it so that it can actually get all the best cardiac output, just like the towel can get all the water out of it. The heart can get actually all the blood out of it. So it's more efficient. So therefore, the twist function of the heart is actually very important. And that is something we'll be doing more and more in the future. Already there are a few studies on that, but not as many. But right now, we have to depend quite a lot on ejection fraction, which is inward motion, and the base of the heart moving to the apex, that is the global longitudinal strain, from where we calculate the global longitudinal strain. Well, thank you very much for your kind attention.
Yes. Dr. Nanda, thank you very much for the excellent deliberation. Now, as you rightly pointed out, GLS has been universally adopted by the cardio-oncologist. But in our coronary artery disease patient, we also have lots of asymptomatic LV dysfunction. And we know if you treat LV dysfunction, their outcome can be tremendously improved. So why GLS is not so popular in the eco-evaluation of coronary artery disease?
Well, I think it is important. I mean, GLS is important, but we are so much used to the wall motion abnormalities and the ejection fraction. So that works. But I think it's useful also in coronary artery disease. There's quite a bit of data coming up now under publication, and some have been published, that is going to be useful in coronary artery disease also. But remember, we don't want to use GLS alone. We always look at both LV ejection fraction and global longitudinal strain. So you need to look at both of them, not just one versus the other.
The second issue is we classify heart failure into heart failure, preserved ejection fraction, and reduce and mid-range on the basis of ejection fraction. Right. But don't you think time has come when we should classify heart failure based on GLS, because 15 to 20 or 25% of heart failure with preserved ejection fraction has decreased GLS. So what is your viewpoint? Should we change the classification based on GLS or continue with ejection fraction?
I think I don't think it's too early to change the classification based on just GLS. I think we should stick with the ejection fraction for now. And as more and more data comes up, then we can utilize GLS also in those particular patients. Remember that we do have some problem with GLS in terms of reproducibility. And also, there is also a problem, vendor problems. Even though the vendors have come together, there is still some inter-vendor variability. So I think we have to be a little bit more careful here, but I'm sure it will be useful again. And we may not be able to classify heart failure just on the basis of GLS, but maybe using both ejection fraction and GLS, we might be able to get a better understanding.
In future, GLS, will it come in the guidelines?
I think so. I think once we get more and more data comes in, there is more validation. It'll come as guideline. Remember, ejection fraction were around for 4 decades, for 40 years, 30 to 40 years. While when it comes to global longitudinal strain, it's been there only for about 5 to 10 years and has been standardized only very recently. So it's a new kid on the block. So before we accept the new kid on the block, we need to make sure there is enough validation.
the data on radial and circumstantial strain is not so useful. Any specific reason? GLS, the data is very strong. Any special reason why it is not so useful with radial or circumferential strain?
The thing is that they have not been standardized yet. The GLS has been pretty standardized, as I mentioned in my talk, but the radial and circumferential strain has not been standardized. And actually, if you think in terms of radial strain, it's something like ejection fraction only. We are looking at the walls of the heart coming together. It's the same thing as ejection fraction to some extent. And so is the circumferential strain. But the GLS is very different, because here we are looking at the motion of the heart, the motion of the base of the heart towards the apex. So it's very different than what we do by ejection fraction. A different way of looking at the heart. That's what it is.
Okay. And the last question, is GLS also operator dependent, or operator dependence is not there in estimation of GLS?
There's a little bit of operator dependence, but there is a lot of dependence on the quality of the echocardiogram. If the echocardiogram is not very good quality, then the GLS is going to be, it's not that much of operator dependent because it's semi-automatic to some extent. And now, of course, the ejection fractions have also become semi-automatic. So they are to some extent operator dependent, but more so in terms of the quality of the echocardiogram. Both parameters.
Thank you, Dr. Nanda. With this, we close this session, and the next session is on a very interesting topic, DAPT after ACS. How long, how short? Dr. Smith has joined. I'll request Dr. Pankaj Manoria to give his talk on this interesting topic. Dr. Pankaj. Yeah, Dr.
Hello?
Pankaj, please start your talk. Pankaj, you are muted. It's okay now. Carry on.
Yeah. My slides are visible now?
Yes.
Yeah. So good evening, everybody. Today I'll be speaking about a very important topic, DAPT duration. How long or how short to be given after acute coronary syndrome. So DAPT for how long? This is a very common question which is encountered by all of us in our daily day-to-day practice. And there are two ways how people or how doctors approach to this question or this problem. One traditional approach is, I doctor do not want or cannot decide about DAPT duration. I prescribe it as long as tolerated by the patient. If the patient cannot or is unwilling to take DAPT, he may stop it. If there's bleeding, he may stop it. Or otherwise, if there's an additional event, then the indication of DAPT is more indicated. So this is a very traditional approach. Now, another approach is, I doctor do not think that the prolonged DAPT should be prescribed in all my patients. And it is in unselected patients, the risk-benefit ratio may compensate each other. Therefore, I will try to individualize based on the ischemic and the bleeding risk. So this is how there are two approaches how doctors or cardiologists approach to this question. I think the first approach is a no-brain approach because they are not applying any brain. They're just blindly starting DAPT and waiting for things to happen and then taking action. Whereas the more rational approach is the second approach in which the doctor thinks, risk stratify the patients on the basis of ischemic and bleeding risk and then decide about the duration of DAPT, which is a more rational approach as far as evidence-based medicine is concerned. So what I do in my talk is I present two cases of acute coronary syndrome in which I did an angioplasty, and then we'll discuss about what are the evidences of longer duration of DAPT. Then I'll discuss you about the evidences for shorter duration of DAPT. Then I'll discuss you about other antithrombotic strategies which can be applied at the end of 1 year. Then we'll discuss about the DAPT score. And finally, I'll get back to the case and discuss and tell you what I did about the DAPT duration in these cases. The first case was a 54-year-old gentleman, acute inferior MI, smoker and diabetic, presented with ST elevation in the inferior leads, as you can see. Left system was normal, and the right showed a complete occlusion of the proximal right RCA. I did a successful primary angioplasty to this patient, and he was put on aspirin plus ticagrelor. Now at the end of 1 year, what am I supposed to do? Either I should continue aspirin plus ticagrelor 60 milligram, or I should switch from ticagrelor to aspirin plus ticagrelor, aspirin plus clopidogrel 75 milligram, or I should stop clopidogrel or ticagrelor and continue only aspirin after 1 year, or I should start aspirin along with rivaroxaban 2.5 milligram BD, looking at the new data which has emerged. These are the few options which I have at the end of 1 year. What I did, I will discuss at the end of my lecture. Now, the second case which I did was a 73-year-old female presented with crescendo angina on effort. TROP-T was negative. He was only a chronic stable angina. LV functions were normal. The left system was normal, and the right showed a focal stenosis in the right coronary artery, 90%, and a successful PTCA and stenting with a drug-eluting stent was done. Again, the same scenario. At the end of 1 year, now what am I supposed to do in this patient now? The 1 year is over, and she has already taken aspirin and ticagrelor for 1 year. Now at the end of 1 year, again I am in dilemma whether I should continue aspirin along with 60 milligram ticagrelor, or should I continue with aspirin and switch from ticagrelor to clopidogrel, or I should stop one in DAPT and switch to only aspirin now, or I should start aspirin along with rivaroxaban 2.5 milligram twice daily. So these two cases I will discuss at the end of my talk, based on the evidences and based on what I did based on these evidences. If you look at the older guidelines of ACS, they say at least 9 to 12 months of DAPT is essential after acute coronary syndrome. Now we have, if you look at now, if you stop DAPT early, yes, there's less bleeding, no doubt, but there will be more MACE. But if you stop late, or if you continue for a prolonged time, there will be less MACE, but there can be more bleeding. So there's always a dilemma between ischemia and bleeding, how to cope up with this, and what is the data which tell us how to deal with this situation. If you look at the evidences for longer duration of DAPT, I mean to say beyond 1 year, we have 3 major trials which have looked into this issue. The one trial was a Pegasus TIMI 54 study. The other trial was a DAPT study, and there was a sub-study of the Charisma trial which looked into that. First, I'll take the DAPT study. The DAPT study was a last study of almost 10,000 patients, in which post-PCI patients were given DAPT for 1 year, and then they were randomized into 2 groups. One, they stopped DAPT, continue only with aspirin, and other, they continue with both aspirin and clopidogrel beyond 1 year, up to 30 months. And the primary endpoint was a composite of death, MI, stroke, and stent thrombosis at the end of 30 months. And what they found was, in those patients in which they have continued DAPT for 30 months, the primary endpoint of death, MI, stroke, and stent thrombosis was significantly less. You can see the p-value of less than 0.001. There were less stent thrombosis, no doubt, but there were more bleeding. Bleeding was significantly more in that group, and also there was slightly more death in the continuing DAPT arm. So again, we are in a dilemma. If you continue DAPT beyond 1 year, it reduces MI, stroke, and stent thrombosis, but at the cost of major bleeding, as was seen in the DAPT study. The Pegasus TIMI 54 study, again a very good study and a good randomized control study. And what they did was, in these patients, they took stable patients who had MI more than 1 to 3 years. They didn't have any on. And what they did was, they randomized into 3 groups. One, they gave aspirin to all these patients, and along with the aspirin, they gave placebo in one arm. And other 2 arms, they give either 90 milligram or 60 milligram of ticagrelor. And they were followed up for almost 3 years. And what they found was, again, if you look at the primary endpoint of there was primary endpoint in both the 60 as well as 90 milligram of ticagrelor as compared to the placebo with a significant p-value. All CV death, MI, stroke were reduced, no doubt. Again, but if you look at the bleeding, the TIMI major bleeding was more, TIMI minor bleeding was more. Though the fatal bleeding and intracranial bleeding was not significant, but the major and minor TIMI bleeding was significantly more when you give ticagrelor along with aspirin in beyond 1 year in stable patients, you can say. So again, the same scenarios, the same thing has been proven once again. You give prolonged DAPT, you reduce MACE, reduce stroke, reduce stent thrombosis, but at the cost of increased bleeding. So again, the point which needs to be emphasized again is you need to risk stratify your patient. You need to see which patient require prolonged DAPT, whether they are high ischemic risk or whether they are high bleeding risk. Then you need to cut down the duration of DAPT. So this is again which was seen in this Pegasus TIMI 54 study with ticagrelor. And one important finding which was seen in all these trials which have looked into prolonged DAPT was that if you had a history of myocardial infarction, means if you have ST elevation MI, and then in those subset of patients, prolonging DAPT was found to be useful. As you can see here, with ACS or without ACS. With ACS, the benefit is more in giving prolonged DAPT. Both stent thrombosis, MI, everything was less if there's a history of MI, myocardial infarction. Again, in all these trials, you can see if there's a history of MI, significant benefit you can see in both DAPT, charisma, and Pegasus. But if there's no history of MI, and then the prolonging DAPT may not be that beneficial. So one thing is very clear, that if you're dealing with a patient who had a history of myocardial infarction in the past, in such patient, the chances of recurrent events are much more. So these patients can be given a chance of prolonging DAPT beyond 1 year. This was seen in all these 3 trials, and also the meta-analysis also showed that history of MI is a strong predictor of future events. So these patients should be on prolonged DAPT. Now, on the one hand, I've told you about prolonging DAPT. Now, on the other hand, there's another spectrum of studies which have tried to cut down the duration of DAPT. That we have evidence for shorter duration of DAPT, not even giving up to 6 to 9 months, much shorter, even 1 month, 3 months, or 5 months. We have evidences. These are the Global Leader study, the Twilight study, Stop DAPT study, Smart Choice trial, and the Detect OCT study. I'll take in very short all these trials. Now, the Global Leader study was designed with the intention that they gave after post PCI, they gave aspirin and ticagrelor for 1 month, and what they did was they stopped aspirin just after 1 month. And they start ticagrelor monotherapy for 23 months in one arm. And in the other arm, they give conventional DAPT for 12 months. And then after that, they stop the aspirin. So we were discussing, we were comparing conventional DAPT versus ticagrelor monotherapy after only 1 month. And what we found was the primary endpoint, the all-cause mortality and everything, it was not significant. So stopping DAPT just after 1 month and starting ticagrelor just after 1 month, doing monotherapy in this Global Leader study was not useful. So the headlines came that long-term ticagrelor monotherapy after statin does not improve outcome as shown in the Global Leader study. Now the very big study, and a very recent study, the Twilight study, has come, and this Twilight study was done with the intention that if we cut down the duration of DAPT up to 3 months and then start monotherapy of ticagrelor, and then as compared to conventional DAPT, you may reduce the chance of bleeding. So in this study, almost 7,000 patients, they were randomized to aspirin plus ticagrelor for 3 months, and then they stop aspirin in one arm, continue only with ticagrelor monotherapy, and whereas in another arm, they continue with both aspirin plus ticagrelor, and the mean duration of therapy was 12 months. And it was basically a safety analysis trial. The primary endpoint was the bleeding, to assess the bleeding. And yes, the bleeding was significantly reduced. If you stop ticagrelor after 3 months, stop aspirin after 3 months and continue only with ticagrelor monotherapy, and beyond 3 months, you reduce bleeding, no doubt. But at the same time, there was no increase in the risk of ischemic events. It was non-inferior. So the ischemic events in monotherapy versus dual therapy was almost the same, but the bleeding was significantly less. So this one thing is clear with this Twilight trial, that if after 3 months of dual therapy, if you stop aspirin in patients with high bleeding risk, you reduce bleeding, and the ischemic risk and the ischemic events are almost the same. Now another study, the Stop DAPT study. This was basically a Korean study which was done in almost 3,000 patients, in which they did a successful angioplasty, and after angioplasty, they randomized patient after 1 month. For the 1 month, they give both dual antiplatelet therapy. After 1 month, they stop aspirin and continue only with clopidogrel monotherapy. Whereas in other arm, they continue with the traditional DAPT for 12 months. And the primary endpoint was the composite of cardiovascular death, MI, ischemic or hemorrhagic stroke, or stent thrombosis, or major and minor bleeding. And what they found in the Stop DAPT study, that the composite of it was, this study the composite endpoint of ischemic raise as well as the bleeding, they was significantly less if you give a monotherapy of almost 1 month or the dual DAPT of almost 1 month. Means you stop DAPT after 1 month, continue only with clopidogrel after 1 month as compared to the conventional DAPT for 12 months. You reduce the composite endpoint of cardiovascular death, MI, as well as bleeding. But the catch point in this study was done under 100% IVAS guidance. Mean the operator who are doing this angioplasty were 100% sure that they have a very good result and their stents were almost undethalized properly. There was no malposition of the stent. So they were very convinced with the result. And we all know that one of the risk factors for stent thrombosis after PCI are the unopposed start or a malposition of stents. And once you're very sure about your result, then you can cut down this therapy to 1 month in this trial. But this result cannot be extrapolated into those studies or those angioplasties which are not done under IVAS guidance. So this study should be taken with a pinch of salt, I must say. Another study, a Japanese study, this was a smart choice study. Again, this study, they did PCI, DAPT for 3 months, they stopped the DAPT, continue clopidogrel monotherapy for 9 months, as well as another arm, they give conventional DAPT for 3 months or 12 months. Again, they found that the composite primary endpoint of the ischemia risk was almost the same, but the bleeding risk, the secondary endpoint, in those arms in which they give only 3 months of DAPT, the bleeding was less as compared to those arms in which they give 12 months of DAPT. So at the same point, this emphasizes that if you cut down the DAPT duration, you reduce the chance of bleeding, which is very much clear with this smart choice study. Now, another study, the DETECT OCT study. This was again done under 100% OCT guidance. And what they did was, they did an angioplasty and they did an OCT of these patients post-PCI. And if they found that the stats are 100%, the uncovered stats are less than 6%, means a very good optimum result. And they stopped DAPT after 3 months. Whereas in those OCT, if they found that if the uncovered stats are more than 6% of the total stats, that means the result is not so optimum and there are few uncovered stats left. And that in that category of patients, they continue DAPT for 12 months. And what they found was, if you have done a very good result, and if the uncovered stats are less than 6%, even a 3 months of DAPT is sufficient. It is equally efficacious. It is equally efficacious in preventing any ischemic events. At the same time, bleeding was less. So this again showed that even shorter DAPT can be useful if we have done a very good result. Now, another approach to these patients of in DAPT regime can be, you give a potent DAPT, means either along with aspirin, you can give either ticagrelor or prasugrel for 1 month. And because we all know that maximum ischemic risk is within the 1 month of the procedure or within 1 month of acute coronary syndrome. So you give a potent DAPT for 1 month, and after 1 month, you de-escalate your strategy. Means you continue aspirin, but switch over from ticagrelor or prasugrel to conventional DAPT, that is the clopidogrel. So if you look into this strategy, there were 2 studies, tropical trial and tropical ACA study. They challenged this strategy. And in the tropical trial, again the same strategy, 1 month of very potent antiplatelet, ticagrelor, prasugrel. And after 1 month, in one arm, they unchain the DAPT, means they continue with a potent antiplatelet, whereas in the other arm, after 1 month, they switch over to aspirin plus clopidogrel. And the primary endpoint was composite of cardiovascular death, MI, and stroke and bleeding. And what they found was, if you switch from a very potent DAPT to after 1 month to a conventional DAPT, you reduce the chance of bleeding, as well as you reduce the chance there was no increase in the ischemia. So the composite endpoint of cardiovascular death, MI, and bleeding was significantly less in this de-escalating strategy, meaning continuing DAPT for 1 month and then switching over to a lesser DAPT, means aspirin plus clopidogrel after 1 month. This strategy also works. Now, another approach to these patients after 1 year is, you can use rivaroxaban 2.5 milligram twice daily in particular subgroup of patients. This was studied in the COMPASS trial. In this COMPASS trial, there were stable patients, stable means post-MI more than 1 year, or any stable angina patients. They randomized into 2 arms. One, they give aspirin monotherapy, another they give aspirin plus rivaroxaban. And what they found was, if you give aspirin along with rivaroxaban, you reduce MACE, you reduce cardiovascular death and MI, but there was significantly risk of more bleeding. And then they further risk stratified these patients. And what they found was, in particular in the PVD group, means if these patients had a history of peripheral vascular disease, and in that subgroup of patients, the net clinical benefit means ischemia as well as bleeding was less, was in favor of the combination of aspirin plus rivaroxaban. So the message is very clear. Beyond 1 year, if there's a history of peripheral vascular disease, then a combination of aspirin plus low dose rivaroxaban can be a very useful strategy. So now, so we know that ischemia and bleeding risk are particularly seen in all these patients. Now we have various scores by which we can predict how the duration of DAPT, and one of the score is the DAPT score. And the DAPT score, they give various points to the various variables. If the age is more than 75, this is -2. If less than 65, 0 points. Cigarette smoking, 1 point. Diabetes mellitus, 1 point. MI at 1 point. Previous PCI or previous MI, 1 point. Lesser diameter of stent, 1 point. Congestive heart failure, 2 points. Graft PCI, 2 points. So if the score is more, then means ischemic risk is more, then you have to give prolonged DAPT. If the score is less than 2, then the risk is less, then you have to give a standard DAPT. And this DAPT score should be done at the end of 1 year. It is not at the end of not at the time of PCI. This be done at the end of 1 year, and then decide at the end of 1 year whether you have to continue DAPT or you have to stop DAPT in this arm. So I'll get back to my case and what I did in my case. This was the case in which I did a successful primary angioplasty. Now I calculated DAPT score in my case. If you look at my case, his age was 654, meaning less than 65, so 0 point. He was a smoker, 1 point. He was diabetes mellitus, 1 point. There was MI at the time of presentation, 1 point. So in the stent diameter used was 3.5, so 0 point for this. So cigarette smoker, 1 point, diabetes mellitus, 1 point, and MI at the presentation, 1 point. The score which I calculated in this patient was 3. So as I told you, if the DAPT score is equal to or more than 2, that means patients require DAPT. Here the DAPT score was 3, so I continue with DAPT in my patient because he has a high DAPT score. Now the second patient was a older lady, 73-year-old female who had a stable angina, no MI at the presentation, a single vessel disease. And what I did, I again calculated the DAPT score. Her age was 73. Meaning -1 point for the age. You can see she was non-smoker, she was non-diabetic. Sorry, she was non-smoker, non-diabetic. So 0 point. There was no MI at the presentation. Stent diameter use was more than 3. There was no congestive heart failure, and there was no vein graft PCI. So the DAPT score was -1. There's no need of giving a prolonged DAPT in this subgroup of patient. So I stopped clopidogrel in this patient, stopped ticagrelor in this patient. But since this patient had a history of peripheral vascular disease, and we all know that in COMPASS study, if the patient has a peripheral vascular disease, then continuing aspirin with rivaroxaban low dose at the end of 1 year is beneficially both in terms of reducing coronary events, but also in reducing peripheral vascular events also. So what I did in this patient was I stopped ticagrelor at the 1 year and start rivaroxaban 2.5 milligram daily along with aspirin 75 milligram. So this was now the very recent ESC guidelines has also endorsed these studies, and in the last month, which was presented the NSTMA guidelines, and what they tell us about the DAPT duration, that if there's a high ischemic risk, they say, then you can continue prolonged DAPT in that high ischemic group. There's a class 2A indication of continuing aspirin along with any other P2Y2 inhibitor if there's a high ischemic risk. As well as they have incorporated COMPASS study also that if there's a risk of peripheral vascular disease, you can use 2.5 milligram rivaroxaban twice daily in that subgroup of patient. At the same time, they have recommended to use this precise DAPT score or ARC HBR criteria to assess bleeding risk. And they say if there's high bleeding risk in this patient, then even a 3 months of DAPT is sufficient. They have included Twilight study in the guidelines. They say even a 3 month study, 3 months of DAPT is equally efficacious in high bleeding dose. You can stop DAPT after 3 months. So these studies which I've discussed have been incorporated in the new ESC guidelines for NSTMI, and you can use these strategy and using DAPT duration. Another de-escalating strategy which I discussed the topic track.
Dr. Pankaj, please finish.
Just the last slide. This is the last slide. This is the last slide only. So this de-escalating strategy can also be utilized in these subgroup of patients. Finally, the conclusion of my talk is there's no universal rule of DAPT. If ischemia is more than bleeding, then long duration. Bleeding is more than ischemia, short duration. You should use the tools available, the DAPT score, precise DAPT score, and above and all, your common sense is very important. And also very important to optimize the stent at the index procedure, which will help you in reducing the DAPT duration. Thank you very much from Bhopal, the city of lakes.
Dr. Smith, you can continue.
Yes, sir. Thank you, sir. Dr. Pankaj, sorry, because of technical issue, I missed first two slides, but I did, important slides were there.
Okay.
So probably today, as we stand, where do you see that the decision point starts rather on the day of intervention we are doing? And can a day come where we can start with a single antiplatelet straight away from the day of intervention, rather than even deciding at 1 month, 3 months, or 12 months, and then 36 months?
Yeah, if you look, yes, strategy should start right from the index procedure. You need to optimize your result perfectly, because if your stent result is optimized perfectly, means there's no uncovered studs left, then you can cut down the duration of DAPT, no doubt. We have studied that almost 1 month is sufficient, as seen in the Stop DAPT trial, 3 months in the Smart Choice trial, as well as Twilight study. So even 3 months of DAPT is sufficient. You can cut down the DAPT duration to 3 or almost 1 month also. But the standard duration, standard dictum still remains. If there's a ischemic and bleeding risk is equal, then you should continue DAPT after acute coronary syndrome or a post PCI up to 9 months or 12 months if there's no bleeding risk. But if the bleeding risk is high, then you can cut down the duration almost up to 3 months also, as seen in the guidelines also.
With use of imaging, again, do you feel that probably we can straight away go for a single antiplatelet?
I think it's too early to say, but there are few studies ongoing that almost on the day of procedure, you can switch to only monotherapy also. You can omit aspirin also. There are few studies in secondary prevention trial also going that only ticagrelor monotherapy right from the day 1, but we need to wait for the results. So far, we have to go at least for 3 months, I can say.
NOACs coming back and replacing antiplatelets. Where do you
see? But not in the acute phase, in the chronic phase, because these NOACs, the rivaroxaban, they have antiplatelet action also. They not only have anticoagulant, but they have antiplatelet action also, which has been found in the rivaroxaban. That is why they are found to be useful in reducing not only the peripheral vascular events also, but coronary events will also reduce. So yes, it is a good strategy in patients of CAD who have history of peripheral vascular disease to stop clopidogrel or ticagrelor after 1 year and switch over to aspirin plus low dose rivaroxaban 2.5 milligram twice daily, which is very good strategy, I can say.
Dr. Pankaj, the basic question is how long the ischemic risk remains after PCI, how long the bleeding risk remains after PCI, and does bleeding risk requires re-evaluation and re-evaluation?
And again, a very, very important point. There's a lot of sub-analysis of these study, and what they came to the conclusion that if there's a history of MI at the index procedure, means ST elevation MI that these patients, they carry the ischemic risk even beyond 1 year, and they have a high chance of recurrent event. So it is very clear that MI at the presentation, then the DAPT duration should be prolonged more than 1 year. If there's no MI at the presentation, there means no properly positive, only stable angina, then you can cut down the duration of DAPT for 3 to 6 months. But if there's MI, ischemic risk remains even beyond 1 year. And yes, and this risk estimation should be done at the time of index procedure, and also time and again it should be done. It should not be left to the patient that once it bleeds, then only you have to stop. This study should not be, this approach is not good. You need to reassess the bleeding frequently also.
Dr. Smith, the time is up. You can conclude this session.
Sir, it was, things are very, very clear, and yet, that this confusion will continue, and with the newer studies probably will have different modes of different routes which will be taken. Thank you, Dr. Pankaj. Thank you, sir.
Thank you.
Dr. Pandey, you can start the next session.
Okay. Good evening, sir. Welcome to this session on a very important issue today. I think the molecule hydroxychloroquine has been there for quite some time, but of late in last couple of months, the molecule which has been talked and discussed, I think if there's any system of TRP rating, this would rate as #1 molecule searched by doctors as well as patients and politicians everywhere. Not only it has been used for tens of years now, at the same time, the molecule has been used for many other conditions also. We have today evening to talk about this molecule and its role in COVID era in different, with different modalities, in different responsibilities. We have Dr. Anil Pareek with us, who is the President of Medical Affairs and Clinical Research with IPCA Laboratories. And we know that IPCA has been phenomenal in making, procuring, supplying, and making this molecule available to a large part of the world at present. Dr. Pareek has been from Bombay, and from where he did his MD in internal medicine and worked as consultant also in the Nair Hospital. At present, working as the president, we can understand how much would he be interested in this molecule to be presented to the scientific world in the right perspective. So I invite him, without wasting any time, for him to talk about how hydroxychloroquine has been repurposed, especially in this COVID era, and what are the implications and long-term use effects, side effects, and whatever we wish to know here. So there are a lot many issues. I really invite Dr. Anil Pareek. Dr. Pareek, it's all yours.
Thank you, sir. Thank you, Dr. Pandey, respected chairperson, and all colleagues who have, doctors who have logged in from across the country on this platform today's evening CME. At the outset, let me thank Dr. Manoria for giving me this opportunity to speak to you on a topic which I'm really, on a drug which I'm very passionately involved for last more than a decade. I think, let me share the screen with you. So this drug has been, as Dr. Pandey said, that this drug has been very widely, has received a very wide publicity for both good as well as bad. And during this pandemic, I think there are very few drugs which have received so much publicity and continues to be widely discussed and debated. But our interest in this drug was much earlier to this COVID pandemic. And we have done some work, which will also I'll talk briefly about that work. And now just going on to the COVID-19 brief timeline. On 31st December 2019, a series of pneumonia cases were reported by China to WHO. And then the clock started ticking. And then on 11th January, first case was reported outside China in Thailand. And then on 30th January, India reported the first case and WHO declared it as a medical emergency. Then we can see that 11th February, WHO, the disease rapidly spread and WHO gave the name COVID-19 to the disease. Then other countries also getting rapidly involved. The disease spread to Iran, then to Italy and several other countries. And on 11th March, the WHO declared a pandemic. And as of yesterday, on 25th October, USA is reporting more than 7 million cases, and India is reporting almost over 5.8 million cases. So India is also, I think, is on the path to becoming the #1 country cases-wise, though mortality-wise, we hope not, but number of cases infected-wise. So that's the story. So what exactly is COVID-19 infection? It is caused by coronavirus, which are a family of RNA viruses that primarily target human respiratory system. And previous outbreaks by the coronavirus has been called as the severe acute respiratory syndrome, SARS-CoV, and Middle East respiratory syndrome, MERS. And that's how this coronavirus is different from the earlier one, and hence it is called as SARS-CoV-2. and this began in Wuhan. And the origin is supposed to be from the bat-derived coronaviruses, and which through an unknown intermediate host, they have spread to humans. This is the life cycle of the SARS-CoV-2 virus in the host cells. It gets entry via the AC2 receptors located on the host cell, and then it gets attached and gets internalized and into the endosomes, and then subsequently there is a release of RNA, and this RNA gets translated into viral replicase polyproteins, and then subsequently into viral RNAs by RNA polymerases. Many virions are assembled, and then finally they are released and they infect other cells. So that's the whole life cycle of, in short, of SARS-CoV-2 inside the host cells. Now, what are the therapeutic options? Naturally, when the disease first began, very little was known about this disease, pathophysiology, and naturally there were no drugs known for this drug, and to have a new drug for specifically for this disease is obviously going to take a lot of time, which can be developed for this. Even the option of vaccine is not going to be easy. It is going to be, although the life cycle, people are attempting to shorten the vaccine development phase, but still it is some time away, and we still don't know the safety and efficacy. That it still needs to be clinically tested. So the best option remains to tackle the disease is to repurpose the existing drugs, and that's what has been done somewhat, and that repurposing has been prioritized naturally, because to get a new drug specifically, research for this disease is going to take a long time. So this is the life cycle and the potential drug targets, how the the virus enters through the AC receptors, and here its entry can be, adhesion can be blocked. Then there are principally our interest is hydroxychloroquine, where it inhibits the entry of the drug at by causing glycosylation of the AC2 receptors, and also its multiplication inside the endosomes. And then we have the drugs like remdesivir and favipiravir, which affects the RNA polymerase and the viral multiplication. And then you have, once the disease is rampant, there is a release of interleukins due to the inflammatory processes, and this interleukins, to stop these interleukin adverse effects, you use interleukin antagonists like IL-6 antagonists, tocilizumab, sarilumab. These have been utilized. The steroids have been primarily used to reduce the damage to the cytokine damage to the lungs as an anti-inflammatory primarily. So this is in brief the various targets for this particular drug. Now coming to hydroxychloroquine in COVID-19, which is our principal interest, today's topic, efficacy. The postulated mechanism of action of COVID-19 is that, as I said, that it interferes with the terminal glycosylation of the cellular AC2 receptors, and thereby inhibiting the virus and receptor binding, and just thus evading the infection. One thing about hydroxychloroquine, by all its mechanism of action, whether it is the immunomodulatory effect or this antiviral effect or other effects, are principally the drug is a weak base, and thus it gets accumulated in the cells, endosomes and lysosomes, and alters the pH there. And this results in inhibition of nucleic acid replication and formation of the new virus particle transport and virus disease. Another mechanism of action is through its inhibition of the toll-like receptors TLR7 and TLR9, and there's subsequently their binding to their ligands, and it inhibits the pro-inflammatory signaling and inhibition. Okay. Go back. Okay. Okay. So I was just discussing about the possible mechanisms other than antiviral effect. So these are it interferes with the glycosylation of the ACE2 receptors where the virus binds, and this interferes in the binding of the virus particle with the target cell. And most importantly, HCQ is a weak base, and it preferentially, because of this, it preferentially accumulates in the intracellular compartments like the endosomes, lysosomes, and this results in increase in pH at that site, and this causes inhibition of nucleic acid replication and formation of the new virus particles and the virus release. Another mechanism is that because of the altered pH in the endosomes, the binding between toll-like receptors, TLR7 and TLR9, this binding is inhibited to their RNA and DNA ligands, and this interferes with the pro-inflammatory signaling, and it interferes with the production and release of the various inflammatory cytokines like interleukin-1, interleukin-6, and TNF. So that's another mechanism in COVID-19, because it's an acute inflammatory stage and there is a cytokine storm. So possibly having the beneficial effect in there. Then now, after, since almost 6 months have passed, some things are becoming more clear who are non-diabetic. So it's a two-way relationship between diabetes and COVID-19. And there are increased coagulopathy, hypercoagulable state. There are formation of antiphospholipid antibodies which are seen in patients who are having COVID-19. I hope I am audible now. Okay, so COVID-19, which is described now as a hypermetabolic, hyperinflammatory, and hypercoagulable state. So apart from the postulated antiviral effects, how hydroxychloroquine can exert beneficial effects in COVID-19 by in terms of reducing blood glucose, in terms of anti-inflammatory, since primarily it's an anti-inflammatory drug. It has known antiplatelet effects. It also reduces antiphospholipid antibodies. So these are the actions which are already known for many years. This is not a new information. So this is how I was interested, as I was telling that I am interested in this drug because I was instrumental in this drug getting approved in India in 2001 in rheumatoid arthritis. That was the first approval. The drug was not approved for malaria, but was approved for rheumatoid arthritis. This is the first approval. And then, this is a study from University of Pittsburgh in JAMA in 2007. And I was really interested in seeing this study, that this is a prospective observational study where almost 5,000 patients of rheumatoid arthritis were prospectively observed for 22 years. And as we know, as that age increases, the risk of diabetes increases, hypertension increases. So here, those rheumatoid patients who are on hydroxychloroquine as compared to those who are not prescribed, if rheumatoid arthritis patients took hydroxychloroquine for 4 years or more, his risk of getting new onset diabetes almost reduced by 77%, which is a substantial thing. And that's how I got interested in this drug in the new indication of diabetes. So this is how we did a phase 3 study where patients who were uncontrolled on metformin and sulfonylurea, we gave one arm hydroxychloroquine, another arm pioglitazone, and we found almost similar reduction in blood glucose. In addition, lipid reduction was found in the hydroxychloroquine arm. So based on this phase 3 studies in 15 medical colleges across India, India was the first country to approve hydroxychloroquine as a first anti-inflammatory drug to be approved in management of type 2 diabetes. Now we know that both type 2 diabetes and atherosclerosis are considered to be having a chronic inflammation playing a major role there. So this is the first approval. Then we did a series of real world as well as phase 4 studies, and we presented at various forums like ADA and the ACE. This is the drug was known to have antiplatelet and antithrombotic effects in the literature, but there was no human study. So we carried out a first human pharmacodynamic study at PGI Chandigarh, and this study is now the most widely referred to study, where it has shown that it has antiplatelet effect and this effect stems from its inhibiting the arachidonic acid-induced platelet aggregation. It inhibits. That's the mechanism where the drug acts as an antiplatelet drug. So this is a series of case studies, by the famous orthopedic surgeon Chanley in 1974, published in BMJ, where he showed that it prevents deep vein thrombosis in patients undergoing hip arthroplasty. So this is prior to heparin was available. This drug is being used there in to prevent deep vein thrombosis in post-operative setting. So these are some of the studies where antithrombotic effects of hydroxychloroquine in primary antiphospholipid syndrome patients have been described. It lowers the levels of antiphospholipid antibodies, as well as it reverses platelet activation caused by antiphospholipid antibodies. So these are all well-known entities described in literature with this drug. So now coming to the back to COVID-19, the first CQ and SCQ, how the beginning started was, as I told you, it started from Wuhan Institute of Virology, where they showed that in vitro study they showed that in low micromolar concentration, chloroquine inhibited the virus. Then they showed the first clinical results was reported by them, where pneumonia exacerbation was reduced and the disease course was shortened in Chinese patients in Wuhan. Then there was an in vitro study in another Chinese Peking University where SCQ was found in vitro to be much more potent than CQ in inhibiting the virus growth. So this is after China, the next actually the studies came from Marseille, France, where a small non-randomized study where 20 patients were on hydroxychloroquine alone, 6 patients were on combination of hydroxychloroquine and azithromycin, and it showed good virological cure in them as compared to patients who were not on any drug and basically the standard therapy without any drug. Then another study from France again showed that 80 mildly infected patients, there was a marked fall in the viral load in the nasopharyngeal swab. Then there was a larger real-world data observational studies of almost 1,061 mild COVID-19 patients where hydroxychloroquine and azithromycin combination was used, and good outcome was shown in almost 91.7% patients. So this was the evidence from France after China. And then subsequently other countries, like this is the Italian study, which showed a good reduction of almost 30% mortality reduction was seen in hospitalized patients who were on hydroxychloroquine versus those who were on the control arm. Then another 2 studies were reported from the New York state, and again, they showed that it showed a good, while early use of hydroxychloroquine showed a good efficacy, and then subsequent study from other countries like Saudi Arabia and Spain, they all showed observational studies showing positive effect and also reduction in mortality. But these were, mind you, these were not the randomized control trial, but they were all observational studies showing beneficial effects on mortality, as well as in the Saudi Arabian studies, they showed that patients, when they were outpatients or prescribed hydroxychloroquine, it resulted into less admission in hospital setting, less admission in the ICU setting, and even reduction in death rate was shown in the Saudi Arabian study. So these are the few positive studies. Then a good number of negative studies have also been reported with hydroxychloroquine. And these have been mainly, we can see that these are all in hospitalized patients and more severe cases where the drug did not show benefit. And another thing is that, the recovery trial in UK, very, very high dose of hydroxychloroquine was used, almost 2,400 milligram in just almost in less than 48 hours. It's a very high dose which was used by them for some reason which they know best. And this showed negative result, and there was no positivity there. Another thing peculiar to hydroxychloroquine, which Dr. Pandey also referred to, that the drug was politicized to a great extent in the US. First, the President Donald Trump reported that this drug is benefit and there are a lot of mortality occurring. So people can use this drug, and subsequently the FDA gave emergency authorization to the use of hydroxychloroquine, and this was was happening. And then this is the recommendation from Ministry of Health, Government of India, where they described the use of clinical management among the clinical management protocol of COVID-19 guidance. They described the role of hydroxychloroquine, and they said that it should be used in mild cases early during the course of the disease. Use during the severe cases and late should be avoided, and a baseline ECG can be done, and you can monitor it, and you can use this drug. That was the advice of Ministry of Health, Government of India. This was on 3rd July, this advice. So this is the ICMR advisory on hydroxychloroquine earlier in March, and then subsequently they again reconfirmed their advice on 22nd May, where they said that you can use 400 milligram of the drug twice a day on the first day, and then 400 milligram weekly for next 3 to 7 weeks for household contacts of confirmed cases, and for almost 12 weeks or more. Subsequently, they extended for healthcare workers to that. But what was observed was the case control study from ICMR showed that for first 4 weeks there was no benefit. The benefit accrued after 4 to 6 weeks, and after 4 to 6 weeks there was a remarkably good benefit in more than 80% of the cases. So due to this observation and knowing the pharmacokinetic of the drug, that it's a slow-acting drug, and we need to actually 400 milligram once weekly may not be sufficient. We need to use at least 400 milligram twice weekly, so that instead of 4 to 6 weeks that we attain the required concentration, we can achieve it 2 to 3 weeks. So we recommended to use it instead of just once weekly, which may not be sufficient. We need to use it
Dr. Pareek, try to finish. We want time for discussion also.
Okay. So this is what was done, and it was this paper appeared in the official journal of ICMR. Then I would like to concentrate now on the safety aspects of the hydroxychloroquine. Adverse event with hydroxychloroquine, which is prior to the COVID era, what we know is basically GI intolerance in 3 to 4% of the cases with acute use, which goes away as you take the drug after food and with a glass of milk. Skin pigmentation and retinopathy, rare cases of retinopathy, these are described on chronic use of the drug. But now, since COVID-19, cardiac side effects are major discussion, and before COVID-19, for last more than 6 decades, there was not much discussion on cardiac adverse effect. That is to be noted. This is how cardiac safety have been questioned of hydroxychloroquine. The US FDA gave an advisory that you need to take only in the hospital setting, don't use in outpatient setting. And while President Trump says that he continues to use the drug, I think so you can see a lot of political undercurrents, and this resulted into that. And then a study in Lancet, which was based on fraudulent data, which was withdrawn. And then WHO, based on that study, which was withdrawn subsequently by Lancet, it recommended to stop the solidarity study which WHO was doing. And then once the study was withdrawn, the WHO reintroduced the drug, and then again that happened. So this is how at this time, when we wrote to the US FDA and EMA and asked them that the drug is there since 6 decades, you should clarify what is there in your database. Why don't you clarify about the cardiac risk? And we requested the US FDA and the EMA both to opine on that. Because instead of reporting on individual case reports, better to see the safety database which is there with the US FDA of more than 6 decades. So the Lancet study was
try to finish.
Okay, this
try
is
to finish.
Okay. So this is, I think, the cloud is now on the cardiac safety is just cleared. This is just recently, yesterday a paper has been presented at ESC where arrhythmic effects of hydroxychloroquine in COVID-19 patients has been seen in different clinical settings, in outpatient, in-house, indoor patients, and also in ICU. And this is a large cohort of 649 patients. And what they observed, and they repeated the ECG, and they found that there was a slight QTC prolongation, but this was not associated with any torsade deep pointis or any arrhythmic effects or arrhythmic death. So finally, in COVID-19 also this cloud has been cleared. Many patients were on 2 or 3 other QT prolonging drugs as well in this study. So you can use the drug for the drug is safe for short-term use in COVID-19. So this is hydroxychloroquine in clinical practice, present, as we said, more than 6 decades, and first anti-inflammatory. And safety reporting should be based on the database driven rather than individual adverse events. And I think here the European Medicine Agency has a very nice way of, if you see the prescribed information compared to the US FDA, where you say the adverse event, how common it is written there, and the cardiac adverse effect come into the very rare and not known category. That's the both cardiomyopathy as well as QT prolongation. This comes in the rare, very rare category. It is less than that. It is featuring in the current European medicine prescribing information. So that's how they
Dr. Pareek, please try to finish now. We are getting late for other sessions.
Okay. So this is the University of Florida, which had almost analyzed 13 million cases in the US FDA database, and they did not find any QT prolongation signaling with HCQ. Instead, they found it with azithromycin and in combination with azithromycin. So we don't see this QT prolongation. Practically, we see slight QT prolongation, but we don't see any torsade de pointis so far with this drug. So as compared to cardiac safety signal in COVID-19, which has been voiced here in the setting of rheumatoid and lupus, there is a beneficial cardiovascular effects of this drug have been demonstrated. This is a study published in the American Heart Association Journal, where you can see that there is less MI events in hydroxychloroquine arm compared to non-users of hydroxychloroquine in rheumatoid arthritis patients. This is another study where coronary artery disease incidence over 10 years period has been reduced to the extent of 68% in rheumatoid patients. This is our papers on hydroxychloroquine safety, that it is safe to use in approved.
Dr. Pareek, please conclude now. The other sessions, international faculty will be thereafter.
So I think I would end with this slide that there is a sufficient signal that hydroxychloroquine can have both direct antiviral as well as indirect effect on glucose lowering, antiplatelet, antithrombotic. There are more trials required to evaluate its use in mild and early in the course of the disease, which are not many trials in this setting. And COVID-19 itself is a pro-arrhythmogenic state due to myocardial damage, hypoxia, and hypotension, and electrolyte abnormalities and other QT prolonged indications. And baseline ECG is a very simple tool available, which we can utilize in high-risk patients and use this drug more judiciously. Thank you for your patient hearing.
I think Dr. Pareek has done a quite elaborate job with the SCQS and its repurposing use in the present COVID era. Many of the points which are coming in the listener's mind are its duration and efficacy. Efficacy, I think, has been proven in n number of studies, and how long it to be used remains a question. We are finding that as the era of COVID is prolonging, stretching, and it seems to be not short ending, at the same time, the indications are clear that prophylactically, if you are taking it, you just keep on continuing it. I hand over the mic to Professor Manoria to continue with other speakers as we are really stretching over the time.
And thank you, Dr. Pandey. We will now move on to the next session, and I'll request Dr. Kunal Srivastav to start the next session. Dr. Kunal, please.
Yeah. Good evening, everyone. Good evening, respected seniors, faculties, delegates, and my colleagues. At the outset, I must say I'm honored to be chairing this session more so because I come from a diabetes background. And I'm chairing a session at Global Cardio-Metabolic Update 2020. Now, I must say the reason for this is because two of our molecules with leading evidence and pioneering innovation have laid their way a path to the hearts of cardiologists. And to decipher these path to the heart of our GLP-1 RAs, we have one very august speaker, none other than Dr. PC Manoria, sir. In just few words, I'll just take 1 minute to introduce sir, who needs not much of an introduction. But sir is Director, Manoria Heart and Critical Care Hospital, Bhopal. Past Professor and HOD Cardiology, GMC, Bhopal. Sir has been mentoring various societies as past Vice President for SARC Cardiac Society.
Dr. Kunal, I think you can skip over now. We are getting late.
Sir, just two more words. Sir is honorary cardiologist, His Excellency Governor of MP and past Editor-in-Chief, Journal Nuclear Cardiology Society of India. So with this brief intro, I hand it over to Sir to decipher the secrets of heart with GLP-1 RAs. Sir, over to you.
No problem. Good evening, everybody. I'll try to finish early. So for the next 15 to 16 minutes, I'll be talking on this very interesting topic, deciphering the secrets of heart in diabetes, CV risk reduction with this special reference to GLP-1 RAs. Now, all of us know diabetes is a den of cardiovascular disease. Cardiovascular disease in diabetes occurs 10 to 15 years earlier. It's 2 times more common than non-diabetics, and a major chunk of population of diabetics, almost to the tune of 52 to 80%, succumb to a cardiovascular disease, mainly acute myocardial infarction. And what is very distressing is that the mere presence of diabetes shortens the lifespan by 6 years, and if an AMI or stroke gets superimposed on it, the lifespan is shortened by 12 years, which is indeed very, very distressing, and we must make attempts to prolong the lifespan of diabetic. So save the heart is the best start in diabetes, and all of us must remember this dicta. When we look at the pathophysiology of diabetes, diabetes executes its ravages on the cardiovascular system by 2 pathways. One is the atherosclerotic pathway, which results in atherosclerotic cardiovascular events and can also result in cardiovascular death. And the other is heart failure, which is also an important cause of death in diabetes. 70% of diabetics die because of an acute myocardial infarction. And indeed, GLP-1 receptor agonists are powered to decrease AMI and stroke in diabetics. What is the first big message for cardiovascular disease in diabetics? You can die of a heart attack even with an excellent HbA1c of 6.5. As you can see, Mr. French died of acute myocardial infarction and his diabetes was very nicely controlled. So the first big message is good glycemic control does not prevent heart attack. The second important message we must remember is that the conventional anti-diabetic medications only provide glycemic control and do not produce CV risk reduction. All diabetes guidelines till 2017 merely focused on glycemic control. But 2016 onwards, there was a burst of CV outcome trials with GLP-1s like LEADER, SUSTAIN, HARMONY, REWIND, And with SGLT2, EMPA-H, CANVAS declared, DAPA-HF, DAPA-CKD, EMPA reduced, and so on. And we now know only two molecules, GLP-1 receptor agonist and SGLT2 inhibitors, have shown improved CV outcomes. And both these molecules are building pillars for cardiodiabetology as we have pillars for heart failure, GLP-1 receptor agonist and SGLT2 inhibitors. SGLT2 inhibitors will be delivered by Dr. Deedwania. The other important thing we must remember is when we are trying to achieve glycemic control, we must try to follow a disease-modifying pathway. And the pathogenetic mechanisms for glycemic control are shown in this slide. As you can see, these are the 8 important pathogenic mechanisms enlisted by DiFrenzo. We have a component of insulin resistance, which is executed at the level of liver, at the level of skeletal muscle and the adipocytes. We have the incretin defect, and the third major defect is the renal defect. Now, what is very interesting that if you use GLP-1 receptor agonist, it targets 6 of the 8 basic pathogenic mechanisms in diabetes: insulin resistance at the level of liver and skeletal muscle, and the incretin defect. And if you combine it with an ACGLT2 inhibitor, most of the pathogenic defects are targeted with these 2 agents. And when we use both these agents in combination, you would have a good glycemic control, decreased weight, decreased blood pressure, and it will target ASCVD, heart failure, and renal protection with minimal side effects and increased longevity, and the heart failure outcome will also be. Now, both these molecules are recommended by all guidelines in the current scenario. Prior to 2018, they were recommended only for secondary prevention, but ESC 2019, ADA 2020 have now recommended for high-risk primary prevention also. If ASCVD predominates, GLP should be preferred, and if heart failure or CKD predominates, SGLT2 should be preferred. Another important thing we must never forget is anti-diabetic medications with BP lowering effect should be preferred, because every 1 or 2 millimeter rise or fall in blood pressure is very relevant and translates into big transformation in CV mortality, because the heart beats 70 times in a minute, 4,000 times in an hour, and nearly 1 lakh times in 24 hours. So if you have elevation of 1 or 2 millimeters, this is transferred to the entire vascular system 1 lakh times in 24 hours. So we prefer drugs like SGLT2, GLP-1 receptor agonists, because they have also a blood-lowering properties. Now, when we are treating diabetes, it is very important to remember that there is an important cross-connect between diabetes, heart, kidney, and liver. All of us know diabetes commonly results in heart failure, and patients with heart failure are at increased risk of diabetes. 1/3 or even 2/3 of patients of heart failure have CKD at the time of diagnosis, and worsening heart failure worsens CKD, and worsening kidney failure worsens heart failure. And diabetes produces NFLD, and NFLD produces diabetes. So in diabetes, we have this important cardio-renal metabolic continuum. And interestingly, SGLT2 targets both these 2 important comorbidities, the CKD and heart failure, which we discussed in detail by Dr. Deedwania. So after the DAPA-HF, the EMPEROR, and the DAPA-CKD, the use of SGLT2 is become ubiquitous in diabetics as well as non-diabetic patients. And we must never forget this cardio-renal continuum, because if you have a combo of HF and CKD, it is a deadly duo and is associated with very high morbidity and mortality. And all of us know SGLT2 inhibitors targets this combo in a very elegant manner. It improves the outcome of heart failure and is powered to improve the trajectory of CKD by slowing the declining EGFR and giving 10 years or so for postponement of dialysis and even kidney transplant. The second important message is heart failure and CKD remain asymptomatic for a very long time, and therefore these agents must be started earlier in the continuum. Now, GLP-1 receptor agonist is a group of agents with decreased myocardial infarction and stroke. And all of us know liraglutide in the leader trial laid the first foundation, this milestone for GLP receptor agonists for decreasing atherosclerotic events. And 3 years later, Pioneer 6 trial with oral semaglutide laid the first foundation milestone of oral GLP-1 receptor agonist. This is the leader trial. You have heard time and again. This is a large trial which compared liraglutide in increasing doses from 0.6 to 1.8 with the standard of care. And you can see the primary endpoint, which was cardiovascular death, non-fatal MI, and non-fatal stroke, a 13% risk reduction, cardiovascular death, 22% risk reduction, all-cause mortality, 15% risk reduction, and all the individual components, if we look at it, statistically significant reduction in cardiovascular death by 22%, non-fatal MI, numerical reduction by 12%, and non-fatal stroke 11%. And this is an overview of all the GLP-1 trials. 4 injectable agents have produced positive results. Leader, MACE decreased by 13%, CV death 22%, mortality all-cause 15%, sustained 6 decrease, MACE by 26%, and numerical decrease in CV death and all-cause mortality. And the REWIND trial, a 12% reduction in the MACE and numerical decrease in CV death and all-cause mortality. And HARMONY, a 22% reduction in the MACE with significant reduction in acute myocardial infarction. And the oral trial with Pioneer 6 oral semaglutide, a 21 numerical decrease in MACE and 51% reduction in cardiovascular death and 49% reduction in mortality. If we look at the injectable agent, you can see cardiovascular death and all-cause mortality is only reduced by liraglutide. That's why it is often preserved. The benefits on atherosclerotic cardiovascular disease are multiples, as you can see on this slide. They act in multiple ways, reduces inflammation, plaque stability, and decreases progression of atherosclerosis. And the same is seen in this. Besides affecting atherosclerosis directly, it also decreases the risk factors for atherosclerosis like blood pressure, obesity, and diabetic control. And we also have observational data on GLP-1 receptor agonists, as you can see in this Danish National Registry, which is a large registry of 516 patients. You can see when liraglutide was used with metformin, there was a 42% reduction in the cardiovascular event, which was not seen with other combinations. GLP-1 receptor agonist is approved by all guidelines across the globe. But the problem with GLP-1 receptor agonist is patient does not prefer injectable therapy, where it is once daily or even once weekly injections are not preferred. And therefore, this led to the exploration of oral semaglutide. And this is the oral semaglutide, which is a co-formulation with SNAC, which acts as an enhancer for its absorption and increases pH and increases its solubility. And the Pioneer 6 trial was carried with oral semaglutide. It was a safety trial in 3,000 subjects, and you can see the results. The atherosclerotic MACE, which was the primary endpoint, was decreased by 21%. Cardiovascular death, 49%, 51%. All-cause mortality was also decreased by nearly 50%. But ML was numerical increase by 18%, and fatal stroke or non-fatal, first non-fatal stroke was decreased by 26%. And this is the all-cause mortality. So Pioneer 6 trial laid the foundation stone for exploring oral semaglutides. And we have the SOUL trial, which is ongoing to test the cardiovascular efficacy of oral semaglutide. So oral GLP-1 receptor agonists may open up a bright future for GLP-1 receptor therapy because it's not an injectable therapy. All of us know SGLT2 inhibitors benefits patients of heart failure and CKD, and GLP-1 decreases atherosclerotic cardiovascular effects. And therefore, it is logical for combining both these therapy for a comprehensive CV risk reduction. So if you combine both these therapy, there will be better glycemic control, minimal hypoglycemia, better cardiometabolic profile, and comprehensive CV risk reduction. But the problem with this combination is GLP is an injectable therapy. But now when oral semaglutide becomes available, it's already approved by FDA, combination therapy with SGLT2 will become easier, and we have the result of the SOUL trial, it will be further increased. So in summary, atherosclerotic cardiovascular disease, heart failure, and CKD accounts for the major chunk of morbidity and mortality in diabetes. GLP-1 receptor agonist minimizes MI in stroke on top of standard of care therapy. SGLT2 improves outcome of heart failure with reduced ejection fraction. They also slow down the trajectory of CKD and postpones end-stage renal disease. Ideally, combination of SGLT2 and GLP-1 should be utilized for comprehensive CV risk reduction, but there are problems in its use. Injectable therapy with GLP-1 comes as a barrier for its widespread use of this combination, but the availability of oral semaglutide, the combination may be likely to be tried and used in future. What is also very important to remember is often one talks of the cost of treatment, but if you use these novel agents, we must never forget that the major chunk of money is spent in treating the complications of diabetes. So if we treat diabetes right from its early age, the overall benefit will be there in use of these costly agents. Thank you very much for your kind attention.
Thank you, sir, for again such an elaborative and yet crisp lecture. Now we have few questions for you. One question is that if a patient is already on liraglutide and develops AMI, what would you do? Would you stop it? Would you continue it? And a counter question to it, if a patient comes to you with AMI, would you initiate liraglutide?
There is no dedicated trial of Dr. There is no dedicated trial of GLP-1 in this subset of agents, But we know that GLP-1 receptor liraglutide has shown to decrease infarct size, has shown to decrease reperfusion injury. So there does not seem to be any logical reason not to use it, but there are no trials, but I don't think it will interfere with the hemodynamic because it doesn't have any adverse hemodynamic effect, so it can be used. And what is your second question?
So would you initiate liraglutide if a patient comes with AMI?
Because there are no trials you can initiate before discharge because it doesn't produce acute effects. The benefits are over a period of time. So although there is no trial and no interference with the hemodynamics, in the absence of trial, it would be logical you initiate before discharge. Okay.
So, sir, while you are initiating liraglutide, GLP-1, what are some of the precautions that you take or some discussion that you have with the patient so that you get a good adherence and patient continues on the treatment?
Usually it has to be given in the early morning. We give pantoprazole half an hour before. And if you start first 2 doses with 0.3 milligram and then switch to the conventional dose of 0.6 milligram and then gradually increase, usually I've seen that nausea and vomiting are minimal.
Thank you, sir. Sir, do you think there is any role of getting C-peptide done or some basic level of C-peptide that should be there to initiate GLP-1 RAs?
It is true that if you have beta cell, this will act in a better way, but we also know that it also affects the alpha cell. So even though the beta cells are minimal, its optimum action may not be there. It can still act through the alpha cell, through the glucagon pathway, and the central effects are also not mediated through the beta cells. So although we would desire the beta cells to be there for an optimum action, but even in absence of a significant C-peptide levels, some actions will still be there.
Sir, one question. Now, GLP-1 RAs, those are protein, and if you take it orally, it will be readily destroyed. Then how does this oral semaglutide actually works?
See, this oral semaglutide works because it is co-formulated with an absorption enhancer, SNAC. When this is used, the pH is increased, its absorption increases, its destruction decreases. This is the mechanism. Because of its co-formulation with SNAC, it is effective and its levels builds up. And the levels attained in the blood are just like the injectable semaglutide.
Thank you, sir, for that clarification. Sir, one question. Often we think that can we combine liraglutide with a DPP4 inhibitors, or maybe more so, can we combine it with SGLT2 inhibitors?
See,
What are your views on that?
Pioneer trials have used this combination, and there's no problem in these combinations.
Sir, I think one more question that comes to everyone's mind. I know you have explained a bit about it on during your lecture, but what and how are the benefits of GLP-1 RA on insulin resistance?
See, we now know that GLP-1 also targets insulin resistance at the level of liver, at the level of the skeletal muscles. And when you use these agents, the level of insulin increases, so there may be some reduction in the insulin resistance and decrease in the glucotoxicity. It also decreases weight, so that may also be contributory. But if you want to target insulin resistance at the level of adipocyte, you have to use pioglitazone. Metformin also targets insulin resistance at the level of the liver and skeletal muscles.
Thank you for that answer, sir. One more question. Looking at CKD, and we know there have been really good trials with the SGLT2 inhibitors. Are there any effect of GLP-1 RAs when we are discussing about CKD?
It has been shown to decrease proteinuria, but in terms of CKD, it is SGLT2, and SGLT2 you will discuss with Dr. Deedwania.
Yes, sir. And sir, I think we'll take one more question, keeping proximity in time. We have seen a really explicit lecture, and definitely the data is very supporting. And I think most of us do agree with the science of GLP-1 RA. But still, we don't see much of an acceptance or maybe much of the uses of GLP-1 RA in routine clinical practice. What could be a reason or barrier for that, and how we can overcome that barrier?
The first reason is somehow, at least in the Indian context, the beneficial effects are not widely disseminated. Secondly, as cardiologists, we do not find much resistance to its use, because once the patient develops acute myocardial infarction, he becomes a very compliant patient. Yes, I'll finish in one. He becomes a compliant patient. For a diabetologist, there may be problem because the patient is not facing an emergency. Secondly, cost is certainly a barrier, particularly when it advised in a non-emergent situation. And so also injectable therapy is a barrier to many patients. But if the benefit is properly explained, which it has so many benefits, I think compliance would increase and more number of patients will get this benefit.
Thank you, sir. Now, keeping time in proximity, the last question for this session. Do you think some of the barriers will be overcome by oral GLP-1, oral semaglutide?
Yes, I feel when oral semaglutide is going to be available in India, which I believe is in the next early year, more and more people will use GLP-1 receptor agonists. And when the outcome trial comes out, it will be a more rational use for CV outcomes. But at the moment, it's already approved by FDA for treatment of diabetes.
Sir, I think we have some more time with us, so maybe I'll go for one more question. Now, if you look at the CVOT with oral semaglutide, the Pioneer 6, as you stated earlier, that it was a non-inferiority trial for getting the approval. So is there any other trial happening for a label approval for CV benefits, or
the SOUL trial is ongoing? The SOUL trial is ongoing.
Sure, sir. Now, in absence of CV benefit, only CV safety, but with subcutaneous semaglutide have proven CV efficacy, how do you see this drug?
See, because oral semaglutide has shown similar levels in the blood and similar benefits in HbA1c and weight reduction, it may be logical to believe that the drug, whether given orally or given by injection, is achieving same levels. It may be postulated that it will have the same benefits, but final results will come from the SOUL trial. Final results have come from the SOUL trial, and this may be a presumption which may be or may not be. But the logic is there because the same levels are achieved, the same reduction HbA1c, the same reduction is weight achieved with oral semaglutides. So there is a hope, but final, we have to wait for the SOUL trial.
So keeping cost apart, where do you think semaglutide would fit into the management of diabetes and patient maybe with high risk? Where you would place it?
If the patient has high primary risk or second or established CVD, this is the first choice. All guidelines have approved it, and all guidelines are recommending as the first drug irrespective of the glycemic control. So ASCVD or high risk primary prevention, this we used very early, and it targets 6 of the 8 pathogenetic mechanisms of diabetes.
Thank you, sir. I think we have now run out of our time, but it was a really enjoyable moment for me to be chairing this session and to listening to you. And thank you for answering all those questions. I think with this, we'll end this session. Thank you, all the delegates, and I'll hand it over to the organizers for the next session.
Thank you. The next talk is on a very burning topic, role of SGLT2 inhibitors for cardio-renal production in diabetes. And the speaker for this session is no other person but Dr. Prakash C Deedwania. He is currently the Professor of Medicine, University of California, San Francisco School of Medicine, Fresno, California. He's a clinical professor, Stanford University, Palo Alto, California. He's a director of the cardiovascular research for the UCSF and one of the most recognizable figures in the field of diabetes, hypertension, lipid disorders, ischemic heart disease, heart failure, rhythm disorders, and preventive cardiology. She's a cardiologist, a preventive cardiologist, and also a rhythm specialist. He has authored numerous landmark clinical trials and more than 500 publications in various prestigious international journals, edited 12 books, and he serves on several editorial boards and national guidelines committee. Dr. Deedwania, please.
Thank you very much for your kind words, Dr. Manoria, and congratulations for organizing this very timely live conference. I must congratulate you for organizing it. I think it's of great benefit, and it's my pleasure to be part of it. So as you already introduced the topic, I'll be talking about SGLT2 inhibitors for cardio-renal protection in diabetes. All of us very well know that in patients with diabetes, ischemic heart disease is the leading cause of death, and together with stroke, it accounts for nearly 80% of the deaths in these patients. Here you can see these data in prospective evaluation in Framingham and other studies that clearly the risk of coronary heart disease is increased by 2 to 4-fold. Heart failure risk, particularly in women, is increased by 5-fold. Stroke risk is also quadrupled in many patients. And this is something that we have been very concerned with. Now, let me try to put it together for you how diabetes can affect all these organs at the same time. On the one hand, diabetes affects the pump of the heart, that is myocardium. That's what is responsible for heart failure. Diabetes affects all the arteries with arterial remodeling and enhancing atherosclerosis. That, of course, causes stroke and myocardial infarction. And as was mentioned already, diabetes affects the kidney, that is the filter. And this is why when we talk about diabetes, we are talking about heart failure, myocardial infarctions, and renal failure. Now, it is important to keep in mind that unfortunately, our past efforts have not been very successful because we have been focusing on one aspect, and I'll be talking about this throughout my talk. That is, patients with diabetes have assault on their vascular system by multiple different pathways. On the one hand, they have hyperglycemia. On the other hand, they have hyperlipidemia. They have other associated comorbidity, and they have hypercoagulability. So today we'll be talking about glucose lowering and newer drugs, but we must not forget that it's very important to remember to have a comprehensive risk reduction in patients with diabetes with the goal of reducing the morbidity and mortality. Now, one of the reasons these new drugs have come on the horizon is that during the effort we were making to control the glucose tightly with the objective of trying to reduce the risk of major cardiovascular event, we found in these three trials, the ACCORD trial, the ADVANCE trial, and the VADT trial, that even though we were successful in reducing the hemoglobin A1C down to 6.5 or thereabout, we were not able to reduce the macrovascular events. However, the microvascular event always respond to glucose control. And here you can see the result of this study. In summary, there was no significant impact on cardiovascular disease overall events, and there was actually in ACCORD, there was increase in mortality. And this increase in mortality, very important to emphasize when you have intensive control of glucose by traditional drugs such as sulfonylurea, insulin, and others, that it really leads to higher risk of hypoglycemia. It has been shown in many studies. I present to you this data from the ADVANCE trial where it was shown that severe hypoglycemia, described as glucose less than 50, was associated with 3.5-fold increased risk of major cardiovascular event. All-cause mortality was increased by 3-fold as well. Cardiovascular mortality was almost increased by 4-fold. Now, that has led the FDA to mandate that all new drugs will need to show safety in patients with diabetes, particularly with reference to those who are either suffering from CVD already or are at high risk. And that led to these numerous trials that you're familiar with many, and that has enrolled more than almost 250,000 people, and that has given us all this data. However, the clinician is confused and always say, which one of these many drugs do I choose? There are too many options, as you already heard. Well, a summary of all these newer drugs and their outcome trials, particularly the CV outcome trials, are listed here. DPP-4 drugs, 4 inhibitors are good, however, good to control glucose. However, they have not shown any beneficial effect in patients with or at risk of cardiovascular events. They are neutral except for saxagliptin, which can increase the risk of heart failure to some extent. You already heard about the beneficial effects of GLP-1 receptor agonists. I'm going to focus on SGLT2 inhibitors because SGLT2 inhibitors have been a game changer in cardiovascular disease as well as in diabetes management. So far, we have data from 4 different agents. Empagliflozin was first, canagliflozin next, and dapagliflozin, and most recently, ertugliflozin. Very important to learn why SGLT2 inhibitor also reduce the risk of heart failure is that at the same time SGLT2 inhibitors block the sodium reabsorption because there is a cross linkage between SGLT2 inhibitor and sodium hydrogen exchanger protein, which is responsible for sodium reabsorption. I can talk about that a little bit more later on. So in summary, when we look at the effects of SGLT2 inhibitors, besides preventing the reabsorption of filtered glucose, it also causes the excretion of sodium, causing what we call natriuresis, decrease in blood pressure, as you already heard, as well as reducing weight in many patients. So it is, and one important benefit of SGLT2 inhibitor, which has not been shown by diabetic drug, is it does not lead to hypoglycemia because these drugs will work only when the glucose is filtered in the renal tubule. And if there is no significant increase in glucose, there will not be a significant amount of glucose in renal filtrate. So that will not be an issue. Hypoglycemia generally is not an issue in these patients. And it does complement actions of other drugs. One very important point to remember that is often not discussed, that SGLT2 inhibitor will still work in patients who may be even insulin resistant or other drugs, resistant to other drugs, because it is not dependent on increasing or improving insulin sensitivity. Like any other drugs, these drugs do come with some baggage. They can increase the risk of recurrent urinary tract infection. because glucose is being spilled. If not proper hygienic measures are used, they can increase the risk of genital myocardial infection. And in patients, most patients with diabetes have hypertension. So when you use these drugs, you have to be cognizant of the fact that you may have to readjust the doses of their antihypertensive drug, lest you will have significant risk of hypotension. And initially, one may see some worsening of renal function, but as I'll show you later on, it actually improves the overall renal function. So in the beginning, we had major surprise that none of us expected. Even the people who were involved in the MPARAG outcome trial expected it. In the MPARAG outcome, 100% of the patient had pre-existing cardiovascular disease. So no surprise that this particular study showed much better outcome. In contrast, in the Canvas trial, 2/3 of the patients are pre-existing CVD. 1/3 of them were sort of what we call primary prevention patients. And the last study, the declared TIMI 58 trial, predominantly had patients who had multiple risk factors but had not suffered from a cardiovascular event. So they were primary prevention patients. Only 40% of them were secondary prevention patients. And as such, when you have different kind of populations of patients in a trial, you must expect, or you must not be surprised by having different kind of results. And this is exactly what was seen. So in order to better understand, some of the people from Harvard did this meta-analysis of SGLT2 inhibitors, taking all these 3 trials, and you can see a very large number of patients. When we look at the patients who had pre-existing atherosclerotic cardiovascular disease, you can see clearly that there is substantial benefit in these patients. On an average, there is about 10 to 15% reduction in cardiovascular event rate. In patients who are with multiple risk factor, on the other hand, whether you take the patients on the Canvas, the 40% of the patient, or in Declare 60% of the patient, you can see clearly that you're not going to see a significant reduction in the MACE events because these patients were at lower risk. In contrast, in patients in both groups, whether they had pre-existing ASCVD or not, there was a uniform reduction in the risk of hospitalization for heart failure. And you can see here clearly that when you look at the combined endpoint of heart failure hospitalization or CV death, there is 20 to 30% reduction across the board. And that tells you something unique about SGLT2 inhibitor in patients who are at risk of heart failure. So there are some questions still remaining. One of the major questions is, can these drugs be used to treat prevalent heart failure rather than just prevent heart failure? Are these benefits observed in all comers with or without diabetes? And in order to clarify that, we are now fortunate that we have results of DAPA-HF trial. The DAPA-HF trial showed clearly that there was a substantial benefit, about 26% reduction in the combined endpoint of heart failure hospitalization or CV death. And what is very important to look at, and some of you may or may not be familiar, if you look at patients who are or have heart failure or at risk of heart failure, you can see here that these curves start separating within 3 months, and they are continuing to diverge throughout the follow-up period of 2 years for a relative risk reduction of 26%. Please also note, this is a very highly significant reduction, and a number needed to treat to prevent one event of CV death or hospitalization for heart failure is only 21. And you can also see here from the DAPA-HF trial that regardless of whether the patient has diabetes or not, the benefit was seen across the field, and actually, if anything, slightly greater benefit in patients without diabetes. So this tells us that SGLT2 inhibitors, if anything, are really a drug of choice now for heart failure patients. And most of these patients are already taking standard drug therapy, so-called the guideline-directed medical therapy for heart failure if they had heart failure already. Now let me switch and talk in a few minutes about the benefit of SGLT2 inhibitors in patients who have kidney disease, because of course you know that diabetes and hypertension together account for 80% of the patients with end-stage or moderate renal disease. And here is sort of the continuum, if you will. You can see that diabetes and CVD and CKD, they interact quite a bit through the traditional risk factor, through other enhancement of CV risk factors that are responsible for decreased renal flow and subsequently the involvement of the glomerulus. And it has been shown that patients who have progressive renal dysfunction, these are the data from a very large cohort of patients. As you can see, 500,000 patients. Even you can see here that as the GFR reduces from below 60, that is a stage 1 of stage 3 of CKD, going up to the advanced CKD, you can see progressively there is increased risk of death from any cause, increased risk of cardiovascular event, or any hospitalization. So clearly, CKD is very important and something that has been ignored. But I request everybody to now pay attention to the GFR that you can get in most of your lab to really look at your patients. If the GFR has fallen below 60, that's an indication of patients having CKD. Here are the data from more than 1 million patients from a collaborative meta-analysis from the CKD prognosis cohort. And I just want to show you again what I showed in the previous slide from NIH, that as GFR drops below 60 here, you can see there is a substantial increase in the risk of cardiovascular mortality as well as all-cause mortality. So I think in India, CKD is very frequently ignored until it leads to renal failure. And I request all the clinicians to pay attention to decreasing GFR and prevent the development of progressive renal disease. Of course, CKD and CVD together are bad companions because CVD is the leading cause of death in patients with CKD. CV mortality in CKD patient is 15 to 30 times, not double, not triple, 15 to 30 times higher than the age-adjusted cardiovascular mortality in general population. The projected 4-year mortality is greater than 50% in patients with advanced CKD, and herein lies the importance of detecting these patients early. And now that we have drugs like SGLT2 inhibitors that can improve the outcome. Now, I want to show several important things in this slide. This is from the MPAREG outcome trial as well as the CANVAS trial. But notice something here. In patients with both doses of empagliflozin, you can see that in the beginning, there will be some reduction in GFR. And this is what has been touted as worsening renal function. Unfortunately, you may have forgotten, but the same phenomenon we saw 30 years ago with the RAS inhibitors, when we use ACE inhibitor or ARB, there is similar phenomenon as the renal hemodynamics are adjusting to the new environment. So similar things is happening here, but overall you can see over time, whereas the placebo patients show progressive reduction in GFR, it is preserved in patients with diabetes here who really entered the study without evidence of significant CKD, because if they had advanced CKD, they were excluded. And you can see empagliflozin in both doses was able to stabilize their renal function. And you can see the evidence of benefit of that because it also showed substantial reduction in the well-accepted renal endpoints of doubling of serum creatinine, renal replacement therapy, or renal death. And this was then reproduced also in the CANVAS trial. Now, this is a summary of the renal events that has been seen in the other outcome trials. And you can see across the benefit, whether patient had pre-existing atherosclerotic cardiovascular disease or multiple risk factor, there is about 45 to 50% reduction in the renal and hard renal endpoints in these patients in this meta-analysis. Now, of course, the largest study for the renal protection with SGLT2 inhibitor is the CREDENCE trial. And it goes without any question, you're well aware of it, that the primary composite endpoint of renal outcome, as I just showed you, was very significantly reduced by 30% relative risk reduction, a highly statistically significant benefit. But in addition to that, these patients with kidney disease, which was the reason patients were enrolled in CREDENCE trial, you see again the benefit of reduction in heart failure hospitalization, almost 40% reduction, the combined endpoint of CV death and heart failure hospitalization, 31% reduction. In addition to that, there is also a substantial reduction in MACE endpoints, again, enhancing the point that I mentioned to you, that patients with renal disease are at high risk of high risk of myocardial infarction. So do SGLT2 inhibitors cover it all? Yes, I can say for most, yes, that is true. In patients who have not had cardiovascular disease but have multiple risk factor, these drugs will prevent heart failure, they will protect kidney, and However, if they have not had high risk of MACE, there is at the present time no evidence that the major adverse cardiac event will be reduced. But patients who have already pre-existing cardiovascular disease, there will be a substantial reduction not only in heart failure and improvement in renal endpoints, but there will be also reduction in atherosclerotic events. The MACE may be reduced with a long-term benefit. We need to show that, but we have to wait for other studies. So broad bandwidth of SGLT2 inhibitor for reducing heart failure and renal protection, you can see starting with those who have low risk versus those who have high risk, it covers the whole spectrum, as we have shown you from the DECLARE TIMI trial as well as the CREDENCE trial. So the report card on SGLT2 inhibitor is that yes, it can also have superiority for MACE, heart failure hospitalization, no question, and these drugs will now become standard drugs for heart failure, and they also provide renal benefit. Now, one of the questions somebody might have is it on top of standard therapy with RAS inhibitors? So mind you, in CREDENCE as well as most of the other studies, all patients were already on the established therapy with RAS blockers. And these are the most recent guidelines with ADA and EASD, and clearly you can see, as Professor Manoria already showed you, that GLP-1 receptor agonist as well as SGLT2 inhibitor could be recommended for patients who have ASCVD. In my opinion, if they are at high risk of major adverse cardiac event, GLP-1 receptor agonist will be preferred. However, we don't understand the precise mechanism of how these drugs prevent the major adverse cardiac event. Now, in patients who are at risk of heart failure or CKD, SGLT2 inhibitors are clearly the preferred agent, and one should avoid thiazolidinediones in these patients because, as we have shown many years ago, there is increased risk of worsening heart failure. And this is something we put together. I was an expert reviewer of this ACC decision pathway. So again, you can see that we highly recommend the use of SGLT2 inhibitors, particularly after a good discussion between the clinician and patient and describing the side effects of these agents. And now there are many that believe that perhaps metformin can be replaced in patients who are at high risk of these events, and one can consider using these drugs even as first-line therapy in many patients. Now, I want to conclude by emphasizing that as wonderful as these drugs are, one drug alone is not going to contain the overall spectrum of cardiovascular morbidity and mortality in diabetes patients, as we learned from the small STENO2 trial, that for comprehensive risk reduction in diabetes, you must control not only glucose, not only use these new drugs, but also control the lipids, also control the blood pressure, which will be discussed in the subsequent panel discussion between my good friend Pankaj Ram and Dr. Manoria. But also remember that it is the control of all these risk factors together that led to the 50% reduction in cardiovascular event. And this is something we emphasized many years ago, which is still holds true, that a comprehensive risk reduction in patients with diabetes is the name of the game. Thank you very much for joining us today, and thank you for your attention. And thanks to Dr. Manoria for inviting me to share my thoughts on this.
Thank you, Dr. Deedwania. All of us enjoy your flashes of experience during the discourse. Now, there are many questions. The first question is, up to what level of eGFR SGLT2 inhibitors can be used?
So I think clearly we lack the prospective data, but now after the CREDENCE trial, I can say that safely one can use it in patients up to the GFR of 30 and above. But based on the CREDENCE data, one can consider it using carefully and really examining the effects on a sequential basis, even in patients whose GFR is down to 15.
The other important question is,
but let me emphasize, should not use in patients with end-stage renal disease, because if you don't have enough renal tubule left, there will be no action for the SGLT2 inhibitors to act. Very important.
Are SGLT2 inhibitors also useful in non-proteinuric or mildly proteinuric CKD? They are immense benefit in proteinuric CKD. So what is the state of affairs in this context?
I think many of the studies, for the lack of qualifying patients in these trials, have not enrolled that many patients. But I can tell you that these drugs will be effective in patients with or without proteinuria. And in my opinion, although we have studies that are in progress right now, they'll be probably working better in patients who have not developed proteinuria, because that will be the early stage, and that is what I would call as a primary prevention of nephropathy.
The other question, how early SGLT2 inhibitors should be used in CKD, in diabetics and non-diabetics?
I think that's a difficult question. Whatever I say will be my personal opinion. I don't think we have effective data about how early they should be utilized. But now that these drugs have been recommended for early use in patients with diabetes, and also remember the patients who are at risk of CKD are also at risk of developing heart failure, and these drugs, we are currently evaluating these drugs for prevention of heart failure, but DAPT did show that it's quite effective. And most recently, just a few weeks ago, we learned that Emperor reduced heart failure patients, I was one of the investigators, also showed similar benefit. I think I can say comfortably that on a clinical basis, on an individual basis, one can consider using these drugs early on in patients who are thought to be at high risk of having subsequent renal involvement, which basically one can say almost all diabetic patients are. Anybody who has had diabetes for a duration of about 5+ years, which is usually the time when patients come for clinical attention, will be at risk of developing CKD if they've already not compromised their renal function. So I would say early use will be quite beneficial, but this is all based on an expert opinion, empiric basis, not based on clinical trial.
Another issue is all trials with SGLT2 inhibitors have used SGLT2 inhibitor on top of RAS blockers. A new thought is emerging is that SGLT2 inhibitors may have greater benefit in CKD patient compared to RAS. So why not use SGLT2 first and then RAS? Is it worthwhile conducting such a trial?
Maybe worthwhile conducting such a trial, but until such trial is done, I would not recommend it. There is no basis for it. There is a significant hemodynamic benefit at the glomerulus level of using RAS inhibitors, and there are multiple other benefits. Similar to SGLT2 inhibitors, RAS inhibitors have multitude of benefits in our body in patients who have CKD. So I would really prohibit or suggest people from not substituting RAS inhibitor for SGLT2 inhibitor. Now, clearly in a patient where they may not tolerate RAS inhibitor for whatever reason, one may consider using SGLT2 inhibitor in those patients, but that's an exception rather than a rule.
Another issue is in a non-diabetic patient of HFrEF who is on AC inhibitor, beta blocker, AC inhibitors. Now he's not improving. You want to switch on another drug. So first you will use ARNI or you'll use SGLT2 inhibitors or both. How do you select this?
That's an excellent question, and I wish I had the answer for it. I don't think anybody knows the answer, but it would probably be reasonable in this area to conduct a study and see which drug should be preferred. Both of drugs are expensive, and I think depending on the local cost or whatever, one can consider one versus the other. I would say if the patient is having significant congestive symptoms, my personal preference would be to consider using SGLT2 inhibitor in these patients, because SGLT2 inhibitors are also what I call a designer or a superior diuretic amongst other actions of these agents. We didn't have enough time to discuss the use of SGLT2 inhibitor in heart failure. I give a whole talk on that and talk about the underlying mechanism of why SGLT inhibitor provides such great effect in patients with heart failure. But just in summary, I mean, they improve the myocardial energy utilization in the failing myocardium. They also are very, very good diuretics. So there could be a theoretical rationale in patients who have more congestive symptoms of preferring SGLT2 inhibitor. But again, we need studies, randomized trials to see which one or the combination of them will be safe or which one should be initiated first.
In heart failure, reduced ejection fraction, we have 4 sets of drugs. What is your viewpoint? All patients of HFrEF, because they have a high mortality, should be on all these 4 drugs, although the sequence of initiation may vary. What is your viewpoint on that?
Again, excellent question. And as you know, heart failure is one of my specialty as well. And we are discussing this right now. What I can tell you for sure is that now SGLT2 inhibitor will become a standard addition on top of all those drugs. Whether it's wise in every patient or not, I do not know. But in many of these trials, particularly the DAPA-HF trial and also the EMPEROR-HF trial, we have added empagliflozin and dapagliflozin respectively in these trials on top of standard therapy. Now, this is not on top of all patients getting the ARNI. So I think that question will remain. So this I already answered in the previous question that Dr. Manoria had, but clearly on top of beta blocker, diuretic, and also on top of ACE or RAS inhibition and mineralocorticoid inhibitors, SGLT2 inhibitors can be added without any question. And this will be, I can tell you that all the European guidelines have already recommended it. American guidelines soon will be recommending it as a standard therapy for patients with heart failure on top of the currently established guideline-directed medical therapy.
And I think the last 2 questions, does SGLT2 inhibitors have an anti-inflammatory effect, and what are your comments on the DARE19 trial which was carried out in COVID, is ongoing in COVID patients?
Yeah, but that's ongoing. I really can't tell you. I think whether they will have anti-inflammatory effect or not, it's possible through indirect mechanism. But again, I would say I think at the present time the data are not compelling to say beyond their traditional effects, and we have so many other mechanisms by which SGLT2 inhibitors work that at the present time I would say not going sidelining with these other things. The studies are going on, multiple other mechanisms are being sought out, but at the present time these drugs unfortunately are still not being utilized even for the patients with established indications such as those we have discussed. So we should be really utilizing it increasingly in patients, particularly I would say at patients who are at high risk of heart failure. It's very important because they could be life-saving indeed. And the cost could be counteracted simply by reducing 1 or 2 hospitalizations for heart failure in these patients.
And the last question, trials of SGLT2 inhibitors in HFpEF are ongoing. Do you have any speculation?
I don't have a speculation. We are part of the Emperor Preserved trial. There are several other trials going on. And unfortunately, as many of you are well aware, we have failed to show any therapy that benefits in these patients. The question that I put forth before all of you is, and that will be covered hopefully in the subsequent talk, is that when we are talking about patients with heart failure with preserved ejection fraction, we are talking about patients who develop left ventricular hypertrophy, who develop decreased compliance of the ventricle, and that, in my opinion, in many patients is already a too far-grown disease process. So yes, it may be possible for prevention of heart failure with preserved ejection fraction if we use these drugs early on. But at the present time, I'm not optimistic that we will necessarily, we will have, yeah, sure, thank you. Okay. Okay.
That was the last question. Thank you very much for the excellent discussion. We now move on to the last session, which is the most important session. And this session is a panel discussion on emerging concepts in hypertension, paving the way for improved outcomes. And Dr. Venkata S Ram will be the panelist and the expert. Dr. Venkata S Ram, as we know, Padma Dr. Venkatram is Director, Apollo Institute for Blood Pressure Management and Director, Blood Pressure Clinics, Apollo Group of Hospitals, Hyderabad, India, Dallas, USA, and Sydney, Australia. He is Vice President, American Society of Hypertension, past Chairman, Board of Governors, American Society of Hypertension, pioneer work in hypertension, and unique skilled communicator of scientific advances. He is rated as one of the topmost doctor in the world of high blood pressure treatment and he has more than 300 publications and a book on hypertension, and he's on the editorial board of numerous national and international journals, and he's the youngest person ever to become Master of American College of Physicians. So, Dr. Ram, the definition of hypertension keeps on varying with various guidelines. ESC 140 by 90, ACC 130 by 80, ISH 130 by 85. Why there is so much confusion, and what is the solution for these different guidelines? And do you have some new definition of hypertension? So what should be the cutoff point for diagnosing hypertension?
Yeah, PC, first of all, let me thank you for asking me to participate in this discussion. As always, it is a pleasure to participate in any medical education conferences that you organize, because you bring a academic perspective to the clinician, which is so important, that you bring a high quality of science. And the preceding speaker, our good friend, Prakash, is such an example that you bring people who know the subject. Couple of things I want to comment on what Prakash said. Ladies and gentlemen, kidney is the heart of the matter of cardiovascular disease. He has mentioned, he almost talked as if he's a nephrologist, not a cardiologist. He mentioned so many times about GFR and kidney function. So ladies and gentlemen, don't ignore those creatinines of 1.4, 1.5 until they become 5. Then they don't need a doctor. They need a dialysis technician. So ladies and gentlemen, pay attention to early stages of CKD and prevent the progression to end-stage renal disease. Now, coming back to Dr. Manoria's comment, is the blood pressure definition changed since 2017 for a reason, because both observational data and limited therapeutic data have consistently shown that any blood pressure that is greater than 130 over 90 over 80 for a period of time can cause significant cardiovascular damage. So if a blood pressure that is higher than 130 by 80 over a period of time, there is what is known as a multiplier effect, where the blood pressure keeps going, and causes significant cardiovascular damage, left ventricular failure, heart failure, CAD, atherosclerosis, carotid artery stenosis, you name it, CKD importantly. So the blood pressure, let us say, I'll give you an example, PC. Let us say if somebody has a blood pressure of 136 over 84. Over a period of time, this 136 by 84 does not stay 136 by 84. It becomes 138 by 88. It becomes 142 by 92. It happens very, very progressively, like a metastatic disease. And a number of analyses now have shown, even people who criticize the new guidelines, that the public health is best preserved if the blood pressure is less than 130 or 80. So I don't think there is much controversy now, PC, as it was 2 years ago. The definition of hypertension according to ACC American Heart is 130 by 80. The definition of European Society of Cardiology, European Society of Hypertension is 140 by 90. And the definition of hypertension according to International Society of Hypertension is 135 by 85. So you are correct, there are 3 definitions, but they all have a common denominator. All of them recommend the goal blood pressure of 130 by 80. So it does not matter which guidelines you want to follow, Indian guidelines, European, American, it does not matter. They all lead to the final pathway of blood pressure less than 130 or 80, except International Society of Hypertension in their guidelines 3 months ago have suggested for elderly patients, blood pressure between 130 to 140, 80 to 90 is acceptable. And by the way, I agree with that. I think for the elderly that is reasonable. But I think in general, there is a consensus, a blood pressure greater than 130/80 over the long term is going to cause significant morbidity and mortality. So this is what is called now new normal blood pressure.
The blood pressure can be measured in the office or at home by the home blood pressure monitoring or by ambulatory blood pressure monitoring. So somebody wants to know what strategy should he employ for diagnosis of hypertension, or a combined strategy should be employed.
Okay, I will give you a twofold answer. As a clinician, as somebody in the clinic, I would now suggest that the best way to get the blood pressure is an automated device in the office. Office blood pressure measurement, OBPM, with an automated device. And there are many good automated devices which take average of 2 or 3. And that is probably the best way to measure the blood pressure. Don't worry about the machine. There is always a tendency when the blood pressure is high to blame the machine. But when the blood pressure is normal, nobody blames the machine. And that is the problem with blood pressure, unlike glycated hemoglobin. So I can openly tell the attendees that all the devices that you have for blood pressure measurement, automated devices that make 2 or 3 times, they're quite accurate, and they should be used in the office. Even if the patient is sitting in front of you, I would use it because it removes the error. That is the best way to do it. Now, as an academician, as a people who write academic papers, they would suggest taking into account home blood pressure measurement in the diagnosis, and that is impossible. Hypertension is very common. It is not like mesothelioma. It is not like asbestosis. So when a condition that is so common, I don't think we should make it so complicated. Home blood pressure measurement is very, very fashionable to talk about because nobody can oppose it. Nobody can oppose home blood pressure measurement. It is very fashionable. It is the in thing. But we do not know the standardization of home blood pressure measurement, sitting position, standing position, when it should be taken. Should it be taken within 3 hours after a meal? Because after taking a meal, the blood pressure falls. And the other thing, most important thing that doctors don't like to talk about in public forum is if a patient calls you saying that my home blood pressure is 150/100, are you going to start the treatment? Or if a patient calls you saying that Dr. Manoria, my blood pressure is 110/70, are you going to stop the treatment? No, the answer is no to both. So home BP, unless it is further standardized, where there is objective reliability of accuracy, how it is taken, it will continue to be discussed, but it won't be the basis for the treatment. Now, the ambulatory blood pressure measurement, on the other hand, has a greater promise than home BP. The difficulty with ambulatory blood pressure measurement is not many doctors have it, and not many hospitals have it. And now most of the hospitals use, or the doctors use, with a cuff. And that is very, very difficult because when the cuff inflates in the night, there is what is known as cuff-related increase in blood pressure. So the compression of the cuff increases the blood pressure, even during the night time. So my suggestion would be, if possible, try to use, if it is available, so-called cuffless BP, if it is available. I know that in many places it is not available, but believe it or not, of all the countries where cuffless BP is more readily available is India. And I say it from experience. I wanted 4 cuffless ABPMs 3-4 months back. They were there within 48 hours, and they are very, very reliable. So my suggestion would be, ABPM does have a place, but I am not a big respecter of so-called cuff ABPM because people don't sleep. if you can get hold of so-called cuffless ABPM, which uses applanation tonometry and estimates the BP, that is reasonable. And one more thing I want to mention. Studies have shown that the correlation coefficient between aortic blood pressure and cuffless ABPM is close to 0.9 or 1. So you don't have to question the technology. I know that for some reason, something that you want to do is prevented and you blame the technology. Machine is not good. Cuffless BP is not good. We don't have, you need to have evidence for that. So PC, my suggestion would be automated office BP, followed if possible the ABPM, and home BP, how much value you want to put becomes highly individualistic, and it is not regulated.
The other common issue from the physician side is we have systolic blood pressure, we have diastolic blood pressure, we have pulse pressure, we have mean blood pressure. What is the importance of each and does it vary with age? What are your comments?
Of course, you know the answer, PC. The pulse pressure is, of course, a measure of the resistance until systole and diastole. Pulse pressure is a parameter of cardiovascular homeostasis and cardiovascular health. And in fact, there was a moment when people from the Framingham study who analyzed it, such as Dr. Franklin, has said that maybe one should use pulse pressure as a target for treatment. But the problem is, as it is, we are not using systolic blood pressure properly. As it is, we are not using diastolic blood pressure properly. What is the point in bringing one more parameter which is less likely to be used? So now both systolic and diastolic blood pressure are important. As you know, in the Indian subcontinent, more studies are coming out with isolated diastolic hypertension in people between the ages of 20 and 40. People have 116 over 94, 120 over 100. By the way, I can attest to it. I have seen it. It is not uncommon. So both systolic hypertension and diastolic hypertension are important. I don't think we have the luxury of separating systolic and diastolic hypertension. But if you ask me, what is a single blood pressure if you have to take, if you are forced to take only one, what would you take? I would say systolic blood pressure. Both are important, but systolic blood pressure is a very strong predictor of cardiovascular morbidity, mortality also.
All of us know central aortic pressure is a better predictor of cardiovascular events in future. So do you think this technology will come to the clinics in future or it will remain a research tool?
Obviously I have to separate my own personal interest and bias from what is applicable. The central aortic blood pressure measurement now is not complicated the way it was until 5 years ago. Now, with technology developed by different companies, central aortic BP is measurable, it is reliable, and clearly it is a better marker of cardiovascular health. Public health point of view, the strong heart study in US has shown that it is the best predictor of cardiovascular morbidity and mortality. But no trial has looked at the outcome of altering the central aortic blood pressure. Small sub-study of ASCOT has shown that therapy that reduced central aortic BP appears to be better than the therapy that did not reduce central aortic BP. Smaller sub-study. Larger studies have not been done. So I do believe the central aortic BP is very sensitive marker of cardiovascular health and prognosis, and it should be utilized on an individual basis, but no guidelines do recommend it because every guideline committee is worried that we are not measuring the usual BP properly. How can we advance this to a more difficult one? No, it's not difficult. How do you want to advance it to a different level? So at least my personal hope is that central aortic BP should be used more and more, despite the absence of prospective studies, and it could be a good target for the treatment, especially combination therapy.
Currently, the focus of attention in all cardiometabolic diseases is shifting from father to son. We have isolated systolic hypertension and young childhood diabetes, young infarcts. So what are your comments on isolated systolic hypertension in the young? What is its pathogenesis and what is the treatment for it?
Isolated systolic hypertension in the young, defining, let us say, not very young, because obviously if it is very young, like pediatric, irrespective of the level, systolic, they need a workup. If somebody has an isolated systolic hypertension in the younger age group, let us say 25, 35, isolated systolic hypertension repeatedly, 150 by 60, 148 by 50, etc. Obviously, this is the reason why I'm not a big fan of telemedicine. You have to listen to the patient's heart to make sure that the patient does not have aortic regurgitation, either by clinical exam or by echo. And in people who have unexplained bone diseases, you want to make sure they don't have AV fistula in bone, not exactly Paget's disease, but Paget's disease-like condition, to make sure that there is no AV fistula anywhere in the body that is driving the systolic blood pressure. If the patient complains of palpitations, warmth, good appetite, but no weight gain, then I think it's easy to get a very cheap test, T3, T4, TSH. So basically what I would do in patients with significant systolic hypertension in the elderly is make sure that they should not have aortic regurg, but if they do, at least that is an explanation. Or just check T3, T4, TSH, but beyond that I would not do any extensive testing.
The mortality in a controlled hypertension at least is 1.5 to 2 times of a normotensive. What is the reason for it and what can be done to further minimize this?
Yeah, this is because typically most people are getting treated between the ages of 50, 60 and 70. So the treatment is begun because these are people who have come for health checkup, or they have some abnormal ECG, they have something creatinine, they have proteinuria, blood pressure is high. So when you treat them, you restore the BP as long as they don't have significant CKD. But the thing is, they had a duration of hypertension that is so long and so residual vascular damage. Just like recently, there was a paper on lipids. People who have prolonged hyperlipidemia, when you treat them, the benefits are not there because they have this legacy effect of chronic hyperlipidemia. So the reason why, despite so-called physical normalization of BP, you're not changing the physiology that much, the longer the duration of hypertension. The studies like VALUE and CISTURE have suggested that if you bring the blood pressure down within 3 to 6 months, which is also a very casual way of saying, then obviously their prognosis is better than taking a longer period of time. So as much as possible, you should prolong normotension and not prolong hypertension. You should treat the moment you see the patient.
Increased sympathetic activity has been noted in the Indian subjects, the Indian heart study, and also in other groups. So if a patient is controlled, will you like to reduce heart rate also if it is elevated by drugs or only by lifestyle modification?
ECU, I'm not an expert in this. I don't know if Prakash is listening, but both of you, when you look at the heart rate in your patient with cardiovascular disease, that paper of the Indian heart study of reverse dipping and the lack of morning rise in BP, very unusual findings, contrary to what has been published all over the world. There's no morning rise, and there is a reverse dipping, very, very peculiar findings in the study that we make sure that we want to validate it in the future. But would you reduce the heart rate by itself? No study has shown. Of course, epidemiologically, studies have shown that the people who have lower heart rate, their survival is better. But whether pharmacological reduction in heart rate with beta blocker, avibradine, in patients who don't have hypertension has not been shown, I don't think it is advocated.
Yeah, I agree with Venkat that I think we should not be using the heart rate reducing therapies. Well, okay, I can put the camera on 1 minute, but camera is not that critical. What was critical is my voice here. Okay, yeah. Okay. So yes, Venkat, yeah, you make a very good point. I would not, in and of itself, use beta blocker or ivabradine. Definitely, I will not use. That really has never been shown to be cardioprotective in these settings. Beta blocker, perhaps in somebody who has hyperdynamic circulation, but many of these patients will have hypertension. Without that high blood pressure, I don't think there is an indication per se by itself. So I agree with you. And I think the high heart rate and of course this reverse kind of dipping, etc., may be indication of poor general health in overall. And that is an indicator of poor outcome.
Dr. Ram, another issue is, when do you advise statins in hypertensive patients?
When do you advise statins in, first of all, indication for statin remains dyslipidemia, remains people at a high cardiovascular risk, even with normal lipids, etc. Hypertension by itself has not been, in any of the guidelines, has not been cited as a reason for using lipids, although studies have shown that patients who are on a combination of antihypertensive drugs and lipids, lipid-lowering therapy, their prognosis is better. So personally, I think people are at high risk for cardiovascular disease if they have blood pressure by itself, not hyperlipidemia, usually 45, 50 and above. They are probably better off with having a statin therapy with the hope that we're reducing vascular disease. There appears to be a 25 to 30% reduction, additional reduction in cardiovascular morbidity and mortality when the blood pressure is lowered along with lipid lowering therapy in comparison to blood pressure lowering therapy itself. But the guidelines remain very vague on this. And people are worried about the cost because that's a social issue. But the cost of the disease is always much more than cost of prevention.
The issue is, when we see specimens of children with coarctation of aorta, there's extensive necrosis above. Most of these children do not have risk factors for atherosclerosis. So what do you think?
Coarctation typically,
hypertension can per se produce atherosclerosis, or lipids, of course, are very important.
No, Prakash might want to comment on it. Coarctation in children and young people in combination with congenital heart disease is a fibromuscular abnormality in the aortic matrix, that kind of a coarctation. And if the coarctation is not detected, which probably happens in a lot of people, then ultimately they do develop systemic atherosclerosis because of high levels of blood pressure. And the specimens, pathological specimens have shown significant atherosclerosis above the aortic coarctation. And experimentally also, when people do experiments by putting a ring, constricting ring about the aorta, there is atherosclerosis. So I don't think atherosclerosis is causing coarctation in young people. I think coarctation might cause atherosclerosis if it is not corrected, especially above the coarctation.
And should antihypertensive medication taken at night or morning, or it does not matter?
It probably does not, and this debate will go on, because suddenly some study from Spain, some community study will say patients who take the medication at night did better than people in the morning. I'm specifically referring to the study, but all the clinical studies which are randomized control trials have used morning administration, except In patients with so-called resistant hypertension, however you want to define it, to me does not matter, then it does make sense to split the medicine, because I don't think there are medications in difficult hypertension that really can put the lid on blood pressure for 24 hours with once a day. You need to give them twice a day.
And then in hypertension, it is only the fall in blood pressure matters, or sometimes the agent is also more important?
I mean, this is a debate that goes on. Currently, if you look at all more recent guidelines, and recently there was a paper, 3.1 million adults in China, it's probably likely to be accepted. Looks like the blood pressure by itself, when it is lowered significantly and maintained that way, is better. And the agents are important in terms of comorbidities, especially CKD that Prakash mentioned, heart failure, etc. In that, I think whatever agents we like, we all have favorites, you can use it. But one should not lose sight of the fact that the blood pressure containment is very important.
Majority of strokes occurs in mild hypertension. What is the reason for this?
Same thing that I mentioned, because by the time we treat hypertension, many of them have established disease, and actually, in fact, I'm amazed how much carotid Doppler is, I wouldn't say used, probably overused in India. Many of them do have carotid disease, so it is just the duration of unknown, undiagnosed, untreated hypertension, or basically very casual treatment of hypertension. Very casual treatment of hypertension.
Well, in addition, I think Dr. Manoria and Venkat would agree that mild hypertension during office may not be as mild as we think. Again, I think it's important to really look at home blood pressure monitoring, or whatever the cuffless 24-hour blood pressure monitoring. The studies have been done that so-called mild hypertensives really are not so mild throughout the 24-hour period. It's the load on the vascular system throughout the 24-hour period that makes a difference. And of course, as Venkat mentioned already, the total duration makes it significant. You know, mild hypertension is ignored quite often. The people have had hypertension for a long period of time, and then they end up having the vascular remodeling.
What are your comments on the newer calcium channel blockers? They say Taxanel and T compared to the time-tested amlodipine. What will you use the new calcium channel blockers?
Right. I mean, newer calcium channel blocking drugs, or you want to call them more conveniently as Japanese calcium channel blocking drugs, because every new calcium channel blocking drug has been from Japan. Cilnidipine, nimodipine, any calcium channel blocking drug. Pharmacologically, there is no doubt that they do have pharmacological actions that differ from amlodipine pharmacologically. And that is the reason why they get that special category in pharmacopoeia, because they have to meet certain characteristics. Certainly, the newer calcium channel blocking drugs, by the way, effect on blood pressure is very similar as amlodipine. When you give the right dose, 24-hour BP, the effect on BP is very similar, which is pretty good because amlodipine is a good antihypertensive drug. But small studies, including in India, looking at ankle edema, they have shown that the newer calcium channel blocking drugs tend to cause lesser ankle edema. In small studies, 30 to 50 patients using Archimedes' principle, putting the foot in the water and measuring the physical volume of it, they have shown the new calcium channel blocking drugs appear to cause less ankle edema. And then switching from amlodipine to newer calcium blocking drugs in patients with proteinuria disorders appears to at least reverse the proteinuria or does not make it progressive. So the effects on the ankle are very much effects that you see in the kidney, but because both are arterial, apparent and deferent arterial. Kidney and the ankle are the same. So there are benefits of newer calcium blocking drugs on these parameters that are a problem with amlodipine. Efficacy-wise, it is very similar, and there is no outcome study between the newer and older calcium blocking drugs on not only an outcome, also not on LVH or anything, but on proteinuria, there are different outcomes. Proteinuria, not prognosis of patients with proteinuria. That has not been shown.
What is the current status of renal sympathetic denervation? It is likely that it may bounce back.
I mean, this is an area of continued interest, and recently that registry has been published, the global registry of renal denervation. I think renal denervation will continue to be investigated for another 5 years. With now what they are doing now is, as you know, because you are more of an interventional person, now they are doing bilateral renal denervation and including the branches with the spiral catheter, so it is a circumferential denervation. And recently there was a study in the European Heart Journal where actually they showed that the renal nerves, most of the renal nerves appear to be most dense at the distal, at the hilum of the kidney. So it is possible the failure of the earlier studies is you did renal denervation most proximally and distally. And so anatomically looks like the recent study, there are nice pictures of that also, how dense it is at the hilum, at the distal. So what is happening now is the technology of ablation is getting better and better, more circumferential, more complete, guided by renal nerve anatomy, which is going to be a good way to do it. Now the question will be on the registry, of course, has shown it's very good, but the people who have done the registry are the same people who have done Simplicity 1 and 2. Nothing wrong with that. Very nice people, by the way, very good people, and non-randomized trials. So I can't tell right now. I think it does make sense to continue the research. The problem continues to be how to identify people who are likely to respond to renal denervation therapy. So far, no trial has shown renal denervation therapy has replaced the previous antihypertensive drug therapy. No study has shown. I know that in global studies, they say from 2.9 medications, it has come to 2.7. I don't know the difference between 2.7 and 2.9 in terms of medications in an individual.
The treatment of hypertension no doubt decreases morbidity and mortality, but does not decrease the number of hypertensive patients. So attention should be focused on primordial prevention so that we have less and less hypertensive patients in futures. Any data available on it, studies available on primordial prevention?
Yeah, studies with trophy has shown you can prevent hypertension, and a study in Brazil, South America, with diuretic clothalidone, they used in trophy they used candesartan. In prevent, they used clothalidone. It prevented the progression of hypertension, and it prevented the development of left ventricular hypertrophy. What problem will be public health policy? Will the governments and the associations have the courage to start pharmacological treatment early on? That takes a lot of courage to do it. Until we come to that courage battlefield where courage takes over the fear, then it will be a problem. Yeah, it can be prevented. At least studies have shown it can be prevented.
If there are any other comments, Dr. Deedwania or any other faculties?
No, in terms of the prevention of hypertension, first of all, I think the primordial prevention, just to make sure everybody understands, is to preventing the disease before its onset. That's the main thing. And I think in China, there are studies that by replacing the salt intake, right, by substituting the sodium to the potassium-rich salt, they were able to show that there was a substantial reduction. What they did was very unique. They took a village in northern part of China, and the entire village, half of the village, they gave the salt substitute. The other half, they continued as usual, and they showed that the people who got the potassium-enriched salt really had on an average about 2 to 3 millimeter lower systolic blood pressure. And that's, to my mind, is a very, very unique finding. And that they calculated, of course, it's calculations, that if such can be attained in the population, in China alone, that can prevent 2 million deaths in a year or two. So I think, yes, there is a strong emphasis on primordial prevention, but very hard to attain.
I think with this, we finish the scientific session. Any comments from any other faculties?
No, I must congratulate you for putting this together in these difficult times, and really, hopefully, we can do the live meeting soon if the COVID ending. But clearly, this was a very good effort on your part. It takes a lot of energy and organization. So thanks again and best wishes.
And I join Prakash. Actually, PC, I know that sometimes it's kind of, you feel embarrassed when somebody praises you on your face, but putting a program, the state of art, and for the audience who are in their comfort of their, they call that drawing rooms in India, in their comfort, what has been published in the last 5 years has been presented.
Yeah.
That means you don't have to worry that you did not read the journal. Most of us were unable to read the journals as it is. So this distillation that brings conferences, of at least the one that you organize, this distillation is a great substitute for them if they missed out on publications for the last 5 years, at least.
And actually, this may be the new norm, and we may be doing more of these in future rather than
often.
Yeah.
We need your cooperation.
Yeah, absolutely. But I think the motto for 2020 is to live through it. That's the main thing right now. Just be safe, be healthy, and be well overall. Thank you again very much.
So thank you, bye-bye, and namaste.
Namaste.
See you again.
Yes.
Thank you. Thank you, Dr. Ram. Thank you, Dr. Deedwania. Thank you, all faculty members, doctorsright.com, and thank you, everybody.